Data was analyzed using SPSS version 28 for descriptive and inferential statistics, and in vivo for qualitative data where I did thematic analysis. Chi-square was used to estimate the degree of association between categorical variables, and binomial regression was used to measure the significance of the association. All ethical considerations and research authorization for this study were also secured. Results and discussion, 388% participants consented to participate in the study, which is 98.5% response rate. Majority of the participants were female, 48%, which aligns with a study done by Noji et al. 2023. Majority were aged between 51 to 60 years, that is 32% of the participants, which was the dominant age. And this aligns to a study done by Jane et al., which showed that the average age of Kenyan farmers is 60 years. The least dominant group was 20 to 30 years, which accounted for 3.4% of the participants. 98.5% of the participants' decision to use agrochemicals was influenced by pest infestation on their farms, 85% by climate change patterns, 71% by disease for disease management, while 52% was for weed control, and 3.9% costs followed by government regulation, which aligns with the findings of Anadwaka et al. Findings revealed that economic pressure played a critical role in the use of agrochemicals for farmers intending to get fast maturity of their crops in the interest of taking them to the market, so they would use more agrochemicals to growth stimulators to get their crops mature faster. The study findings also revealed that 98.7% of respondents were aware of climate change, which agrees with a study by Islam et al. In 2021. 96.4% observed change in pest pressure, weed growth, and disease incidence due to climate change, aligning with a study by Tudi et al. Decision on agrochemical use was influenced by recommendations from an agricultural extension officer, 87%, previous experience, 72%, and recommendation from other farmers at 48%. Regression analysis showed statistically significant association between climate change observation and number of methods used to apply the agrochemicals. And respondents who reported having seen or noticed changes in climate change were 1.2 times more likely to seek or consider expert guidance on their decision to use agrochemicals compared to those who had not observed any climate change. 60.8% of respondents used agrochemicals on a weekly basis on their farms, and 0.3% had never used agrochemicals. 67% did not have future plans of eliminating use of agrochemicals in their farms. Only 8.8% had such plans. And of those who had future plans of eliminating use of agrochemicals, only 29% were members of farmers' cooperatives, while 18.6% were not members of a farmers' cooperative. Sorry. Also, the findings revealed that high use of agrochemicals among fresh produce farmers, in terms of what kind of chemicals they were using, I found that 96% were using pesticides, followed by fungicides, insecticides, and the least used were herbicides. In conclusion, from our study, climate change patterns result in development of high pest burden, resistance of pests to agrochemicals, and this influences the frequency and use in terms of volume of agrochemicals on farms, of course ultimately impacting health of the farmers and also the users of the farm produce. Farmers who relied on agrochemical extension officers for advice on use of agrochemicals were more likely to practice safe use of agrochemicals. Fresh produce farmers who noted extreme weather patterns were more likely to seek recommendations from experts or agricultural extension officers about the agrochemical use. Economic pressure was a very key or critical aspect in terms of use of agrochemicals, where most farmers reported using growth stimulators to make their crops mature faster in the interest of meeting the market needs. And membership to farmer cooperatives was significant in influencing future plans of eliminating agrochemical use. Recommendations: there is need to work collaboratively to support fresh produce farmers in the county, in public agricultural extension services, which play a critical role in increasing protective use of agrochemicals, therefore protecting the health of the community. Through training, fresh produce farmers can identify climate change effects early enough and make informed decisions in their farming practices. And we noticed that membership to farmer cooperative groups had a link to the likelihood of the farmers reducing or planning to eliminate the use of agrochemicals. So it was important to belong to a cooperative group in terms of getting knowledge and education about agrochemical use. There is need to provide information to help fresh produce farmers consistently make decisions from a point of extensive knowledge and information about current climate change issues, best practice in fresh produce farming, and sustainability in food production, and ultimately protecting the health of the community. That's the end of my presentation. Thank you.
Thank you so much, David. Let's give him a round of applause. So we'll just take one question now.
What's next? Where does this research go?
Thank you. We are on the step of dissemination, so we are trying to create a lot of awareness, especially with the county government, because we've noticed a gap in training, knowledge gaps among the farmers, because most of them are just applying chemicals without thinking about what impact does it have beyond the farm and what impact it has to the community. And also awareness of other alternative methods. So I am looking at alternative methods to agrochemical use. So non-agrochemical use of pest control. There are a few pest control methods which I'm considering, so it's something that we're already starting to work on, but majorly dissemination of the findings, especially to the stakeholders and county government. Yep.
Thank you so much, Prof.
Thank you, David, for the presented presentation. In your findings, you did indicate that your regression analysis gave an odds ratio of 0.87 with a p-value which was significant. How can we interpret that those results? And secondly, if you look at your title, you have given us the title of climate change and the use of agrochemicals. And when I look at your conclusions and the recommendations, really I don't see those conclusions and the recommendations being carried by your findings. Please, maybe you can comment. Thank you.
Okay, so
and what does that odds ratio of 0.87 and a p-value of 0.01 mean to us?
Okay, I'll start with that. So I've said the analysis showed significant association. They would use fertigation, they would use just pouring of the agrochemicals on the crops with the hope that it would have a better effect. So those who had seen climate change impacts affecting their crops chose to use very many methods. So they would apply the same chemical using different methods. Odds of 0.87, almost 1 time higher than those who had not observed those changes. About the conclusion and aligning it with the title, I think, yeah, it's something I would look at. Thank you, Prof.
Thank you, David, for that area of study. It's a very important area, really. Mine is a question on the choice of the study area. Although you say it is purposefully chosen, I'm just wondering, is Nakuru the only area where we have fresh produce grown in large scales in Kenya? Bearing in mind that the science does not go with convenience. My second one is on your topic. You have clearly stated that you are looking at climate change and the use of agrochemicals. What climate change phenomena did you find in Nakuru that you can relate it to the use of these agrochemicals?
I'll start with the second one. The biggest challenge in terms of climate change in Nakuru is changes in precipitation patterns. The normal seasonality of rain has really changed. So the dry seasons are longer than the rainy season. So whenever rains come, farmers tend to do as much as they can because most of the agriculture is rain-fed. So they do as much as they can to take advantage of the rain to increase their produce and meet the market demands. And from that point is where now we see most of them are using growth stimulators and other chemicals that were not formerly used. So majorly changes in precipitation or rainfall patterns. And of course, increase in temperature. There are few areas, especially in Mount Narok, where pests that were not there present in like 10 years from the questionnaire 10 years ago now are present in that area. So it increases their use of the agrochemicals. Why Nakuru, you asked? Yes, I chose Nakuru because Nakuru is key number one in production of large scale and also small scale agrochemical or fresh produce, but not so much because of the production, but because of their use of agrochemicals. I did not mention here, but nationally, Nakuru uses the highest proportion of the imported agrochemicals in Kenya. So I think because of the large geographical area, commercial use, I got data from Agricultural Association of Kenya. The highest proportion of agrochemicals imported in Kenya go to Nakuru County. I wasn't able to incorporate it here because of challenges of space and time. Thank you. Thank you.
Hello everyone, my name is Wako Mamo. I'm an MSc first year student epidemiology. So I'm just presenting the abstract, my research proposal. So the topic that I will be handling is ethnobotanical and epidemiological assessment of herbal remedies for management of zoonotic disease in Lysamis subclicated rats, public health burden globally and also in Kenya, especially in the pastoral areas. Lysamis, being a pastoral place, heavily relies on this herbal due to limited health facilities around. So, and then it is also important to know this indigenous knowledge on herbal treatment, which is has not been studied or is undocumented. So the problem statement, there is no enough data on herbal use in managing zoonotic diseases like the brucellosis, which are common there, the rabies and the anthrax. Then also there is a threat to preservation of this indigenous knowledge, or especially of the herbal remedies that we use in managing these diseases. And also for the need of evidence to support the potential integration to the One Health system. The reasons are, if we do this, it will provide basic data for the policy and researchers. It also support the cultural heritage preservation. Yeah. And the main objective is to assess the topotanical and epidemiological aspect of the herbal remedies we use in managing the zoonotic disease. The specific objectives are: 1, to document remedies used. Second one is to determine the prevalence of their use. And then the third one is to assess the perceived effectiveness of those herbal drugs. The study area is Lysamis, that is a northern part in Marsabit County. The area is characterized by, it is arid, and the pastoral community occupying that part. The study design I will use, I will be using the cross-sectional design, but I will use the both mixed. I will combine the, I will do design I will use is cross-sectional description. And then my target populations are the community members, the household, the herbalists, those traditional healers, and also the facility to get the report of the zoonotic diseases, the one they manage. The sampling strategy I use, I will go the judgmental, the purposive sampling for herbalists, and also do some clustering and stratifying sampling for the households, and also selections of health records. The data collection, I will do interviews, the focus group discussions, and also provide some structured questionnaire from the health from those concerned, and also the records from health facilities. About analysis, I will going to use both thematic and descriptive, thematic analysis and descriptive statistics to analyze my data, and if possible, I do the correlation. So some of the expected outcome from this result may be to document the herbal remedies used and their patterns, the data on prevalence and perceived efficacy of those remedies, and also some other recommendations. Of course, before doing the ethical consideration sought from the university, and also those will be interviewed, the concept, the informed concept. Yeah, thank you.
The next presenter kindly.
Thank you, Mamo, for the good presentation. I have one question. You indicated that you are going to do questionnaires and visit the health facility. I don't know whether it would have been nice to do an in vivo study to see whether those botanical compounds are working or not, so that you can actually quantify that it's working or not, if you can do some research in the lab. Thank you.
Okay, we'll try.
Thank you very much, Mamo, for taking that initiative. I recommend that you work closely with the faculty members. We have a very rich faculty so that you can enrich your work. Actually, that's the way to go, so that we don't rely on synthetic medicine. If there are products which we can develop, think of an innovation. So what Doc is telling you, think of doing the analytical analysis of those plants so that we can come up with some conclusion. The university will support you, so please link with the faculty.
Thank you.
Get the next presenter, please. That's so that because we are really trying back.
So we only take one question because if they see, they should know that we don't have a lot of time. You can ask just one question and please be strict where it is. And announce that one to the best time and announce. We are out of time.
Next, who was coming after Zainab? That was Mercy Tonui. Had you sent your presentation to the email? Okay, quick.
Good afternoon, everyone. My name is Mercy Chepkoech Tonui. I'm Master of Science in Epidemiology student. I'm honored to be here today at the MASTIC 2025, and I'll be presenting my research titled Effective Use of Electronic Health Records in Tuberculosis Surveillance. This is a survey of Tigania East Sub-County, Meru County, Kenya. TB is a major public health concern, and globally, there is an estimate of 10,000 million people falling ill from tuberculosis and 1.5 million people dying from tuberculosis annually. And tuberculosis has been classified as a notifiable disease under the Public Health Act, Cap 242. And Meru County has been listed as among the top 10 many new cases are arising from Tigania East Sub-County due to tuberculosis, and there is limited healthcare infrastructure. Meanwhile, as we are fixing this, electronic health records, these are a digital version of patient health records. Unlike the manual paper records have been used for quite a while, but right now we are adopting the new system, which is the electronic health records. And this will really help because data can be stored, it can be utilized, it can be managed, and also disseminated electronically, unlike using manual paper records. Okay, so thank you. For the problem statement, There is incomplete data and also delayed reporting of TB cases, which hinders timely intervention from the public health authorities, and this increases the rapid transmission of tuberculosis. There is also limited data accessibility of TB cases due to incompleteness, maybe delayed reporting, and these issues lead to delayed diagnosis, poor treatment or poor timely treatment of TB cases, hence leading to higher or rapid transmission of TB cases. And this has undermined TB control efforts. Globally, this study will support the WHO health record use, will advance both the national and also the global TB control efforts to eradicate tuberculosis by 2030, and supporting the United Nations Sustainable Development Goals. This study aims at answering 4 research questions, and the first one is, what is the completeness and accuracy of electronic pre-treatment health records used in TB surveillance in Tigania East Sub-County, Meru County? And the second research question is, what is the update frequency of electronic treatment health records used in tuberculosis surveillance in Tigania East Sub-County, Meru County? And the third research question is, what is the documentation of electronic post-treatment health records in tuberculosis surveillance in Tigania East Sub-County, Meru County? And the fourth research question is, what is the utilization extent of electronic health research records used in supporting tuberculosis surveillance in Tigania East Sub-County, Meru County, Kenya? The research objective, this research aims at the broad objective or the main aim of this research is to investigate the effective use of electronic health records in tuberculosis surveillance in Tigania East Sub-County, Meru County, Kenya. And the specific objective that arises from the research questions that I said earlier, the first one is to assess the completeness and accuracy of electronic pre-treatment health records used in tuberculosis surveillance in Tigania East Sub-County, Meru County. And the second specific objective is to identify the update frequency of electronic treatment health records used in tuberculosis surveillance in Tigania East Sub-County, Meru County. And the third is to examine the documentation of electronic post-treatment health records used in tuberculosis surveillance in Tigania East Sub-County, Meru County, Kenya. And the fourth is to determine the utilization extent of electronic health research records in supporting TB surveillance in Tigania East Sub-County, Meru County. And this research is based on this conceptual framework. We have the independent variables and also the dependent variable. So I've got 4 independent variables, and the first one is electronic pre-treatment health records. The second is electronic treatment health records. The third is electronic post-treatment health records. And the fourth independent variable is electronic health research records. And each independent variable has their own sub-variables. And the dependent variable here is effectiveness of electronic health records in tuberculosis surveillance, and it has its own sub-variables. For the research design and methodology, I'll be using, this research will use the study design, which is cross-sectional survey design. And the reason as to why I chose cross-sectional survey design is because data can be collected at a single point in time, hence providing a snapshot of the TB surveillance and also the utilization of electronic health records. For the study population, it will include healthcare facilities with operational electronic health record systems. The reason I said operational, because I'm doing electronic health records, I'll use operational electronic health record systems. Then healthcare providers involved in TB care, TB patients whose data are recorded in the electronic health record systems. For the sampling technique, I have 3: simple random sampling, stratified sampling, systematic sampling. For the different wards in Tigania East Sub-County, I'll use simple random sampling. For stratified sampling, I'll select healthcare providers and healthcare facilities. And then for the systematic sampling, it will be the TB patients in the electronic health record system. The data collection instrument that I'll use is structured questionnaires. I'm sorry I didn't include structured, but structured questionnaires to collect the data from the healthcare providers. Then data will be analyzed using a statistical package for social sciences. Then for data, the findings will be presented using tables, charts, and graphs. And the reason I'm using wheel is because I've not gone for data collection, so I'm still heading to that step. For ethical review, we have informed consent and data anonymity will be ensured. And then I'll sought approval from MIREC, the Meru University Institutional Review Committee, of which I've already received that. So I'll be obtaining the approval from NACOSTI and then from other Meru County Health Departments. And then data storage will follow strict security standards like encryption. Yeah. Expected results, I've not collected data, so my expected results will be identification of the current level of completeness and accuracy in electronic pretreatment TB records, evaluation of how well electronic post-treatment data is documented and archived, the measure the degree to which EHR are currently supporting surveillance efforts, documentation of systemic or user-related challenges in EHR implementation and use. For the potential impact, accurate and timely electronic health records data will support early TB case detection, faster treatment initiation or prompt treatment, and reduce transmission rates. Then the third is evidence generated will guide county and national health authorities in formulating more targeted TB control policies and digital health strategies. And the last one is by promoting digital innovation in health surveillance, this study advances sustainable development goals, which is 3.3, which is talking about communicable diseases, how to end communicable diseases. For example, AIDS, tuberculosis, and for my case, tuberculosis, which targets ending the TB epidemic by 2030. Thank you.
Thank you so much, Cherotich. One concern or one question, anyone?
Yeah, thank you. I think I'll just pass a few general comments. One, I would wish that you define effective use more clearly. Then objective number one, accuracy and completeness is a double-barreled objective. So you would want to separate them. In your conceptual framework, you have two parts, the independent variables and the dependent, all coming up to 5 items, yet in the objectives there are 4. So would you factor in how you are going to measure the dependent variable? And lastly, you have talked of potential impact being promoting utilization that has a connotation of suggesting an intervention. Thank you.
Thank you for that.
Yeah. Thank you so much. I think we can give a round of applause. Next speaker. Next speaker, according to the program, we have, is Jacqueline Gatabi around? You can take the floor. Then after you, is Julius Nyinkil. Julius, is yours ready? Yeah, so you present after her. Okay.
Good afternoon. Is it yet afternoon? Yeah. I'm doing a presentation on exploring childbirth experiences among the adolescents in Met South Sub-County, Meru County. And before I continue, I want to take this opportunity to appreciate the chance given and also honor and appreciation to my supervisors, Dr. Mary Joy Kaimuri and Dr. Peter Kairemia. So I'm Jacqueline. I'm a MSc student, School of Nursing, doing midwifery. So disclaimer is the presentation I'm about to do is an ongoing work. So part of the data that I'm presenting is half of it. Yeah, so I heard you saying that the topic is exploring childbirth experiences among the adolescents in Imenti South Sub-County, Meru County, Kenya. We are saying that part of the introduction is WHO defines adolescents as those who are aged between 10 to 19 years. And we appreciate that adolescents' pregnancy is a real burden, and globally it accounts for 11% of child births, with low middle income countries taking the lead. And in a Kenyan setup, the adolescents' pregnancy makes, or rather the national average is at 18%. When you compare it to Meru County, we are at 24%, which is higher than the national average, which is 18%. And of key to note is that between January and May of the year 2024, 15,000 girls dropped out of school. So for the problem statement, we appreciate that we've seen that there is the national burden, where we are at 18%, and the Meru County burden is at 24%, which is higher than the national government, and that rate of 15,000 girls dropping out of school. And for the study site, which is Imenti South Sub-County, the cases of adolescents' pregnancy is at 4,499 cases, ranking Imenti South Sub-County as the top 4 in the Meru County. So the aim of the study is to explore childbirth experiences among the adolescents seeking services at Imenti South Sub-County. And the research questions is we want to explore the experiences of adolescents with the different stakeholders across the care continuum, and also to what extent are the health care services responsive to the needs of the adolescents. We'll also explore on the met and the unmet childbirth needs of adolescents across the care continuum. So we appreciate that the study is significant because this is a special population that is vulnerable and at higher health risk. And then also we'll appreciate that the service providers have insufficient understanding or focus on their specific needs. And we also lack comprehensive evaluation on the quality and accessibility, especially for the adolescents, sexual reproductive health services, so which is also a gap at Imenti South Sub-County. Allow me to take us through the research design and the methodology. So the research site is at Imenti South Sub-County, that is in Meru County, Kenya. And for the standing design, used descriptive qualitative design. This one helps to explore the adolescents' experiences as they narrate, their experiences and their perception about the journey of pregnancy to childbirth. The study population is the adolescents who are aged between 15 to 19 years, and also those who are not past 12 weeks after delivery for the recall purpose. Then the recruitment is, of these participants is from the Ministry of Health comprehensive registers, and the sampling strategy is the maximum variation purposive sampling, which helps to capture the relevant participants' diverse experiences. You'll appreciate that for the qualitative study, the participants, we use a small sample size. And in this case, I already explained that the sample size is half that I'm presenting. So 15 participants will be targeted, and 7 of them were interviewed. And this is adjusted based on the emergence of the themes until we achieve the data saturation. So the in-depth interviews were done using the in-depth interview guide, and the data analysis is done through thematic analysis using the Envivo 15 software, where transcription, translation, coding, categorization of the themes and the sub-themes was done. So for the ethical consideration, clearance from IREC, Nacoustic, Meru County Health Department, and also Kanyakine, and also not forgetting about the informed consent, considering we are dealing with the minors. So the asset form and the parental or guardian consent was observed for those who are below 18 years. So allow me to do the presentation of the findings. So these findings are categorized by themes, and then also the verbatims, which are represented by the suggestions or the experiences of the participants themselves. So considering the adolescents' experiences with the stakeholders, the theme that came out was about stigma, rejection, and isolation. So these participants experienced a lot of stigma from their family members, from schools where they were students, church, and also the community. That is the community, part of them are the neighbors. And these were the key quotes. Some said, church members called me a prostitute. Pastors offered no support. And then others say teachers announced them and ashamed them in the public. And they could tell the other students, don't sit near her, she's pregnant. So the impact about it is there was a lot of isolation, and then also the delay in health seeking. Majority of them began their antenatal clinic at around 5 to 6 months. And also it had some challenges with the extended family where they were drawn from the home, and also got support from their extended family members. Like majority of the group that came for their support was the grandparents. For the healthcare service responsiveness, the theme that came out was the inconsistent care and the resource barriers. And there were some mixed experiences in where some health providers were available to support them. To some extent, they also experienced negligence and also some bit of unexpected, language choice during the care. And these are some of the quotes. They say, nurses rubbed my back and I was encouraged. And others also say, I almost gave birth alone because nurses ignored me. So this brings out some challenges, especially on the system. They said that the long queues, the staff shortages, and the lack of equipment brought a lot of challenges, and so most of the time they had to go to private sector to get some services like the ultrasound. They also complained about cost barriers because I remember they are students, so they don't have that resources, and especially where they needed to go to seek for services like ultrasound from the private services.
2 minutes.
Thank you. So the final findings on the met and the unmet needs, the gap that came out was, the theme was the gaps in education and tailored services. And the lacked family planning, education, and minimal postnatal guidance was provided. And these are the quotes. No one taught me about condom use. They only said I breastfeed, nothing about cord care. Remember, postnatal guidance is very key because this is their first time experience. And the recommendation was for free health care and also adolescents friendly spaces, peer support groups, to help, especially the time of isolation. So for the recommendations and the conclusions, we are saying that health care needs a lot of improvement. There is also health education and support, and especially those who are providing services, because this is a very sensitive group and also with special needs. In conclusion, we'll say that we need to combat stigma through training, removal of financial barriers. They really cried for free services because they are students, and also provide youth-friendly services. Yeah, so I think that's it. So as I finish, these adolescents need support and not shame. So their voices must guide solutions. Thank you.
Thank you so much, Jacqueline. Let's give a round of applause. Yeah, that was a wonderful topic. Now, 1 or 2 reactions so that we can break for lunch. Dr. Ruto and Daktari up there. So please, even after lunch, make sure you come back so that you can listen to the other presenters.
Jacqueline, thank you very much for the well-presented work. I want to inquire one thing when you talk about health outcome. I don't know whether you looked at these adolescent girls and fistula, for example, as a health outcome, because they are still very young. What about, did you see them having challenges like fistula? The second one is you talked about lack of family planning, and you didn't show us how many had access to family planning, how many didn't have. Thank you.
Okay, thanks, Jacqueline, for your presentation. Qualitative studies are very interesting. It might not be in your scope, but I'm wondering whether you're asking these adolescents how to prevent this, because you see there's a long-term impact of them dropping out of school, and it's really like their entire life is affected. Meru is not doing very well, the statistics are high, and they can only increase without these trends of human rights, my freedom and all. And also the concern, even the judges, our laws are not in tandem with our practices, because who is having sex with these children? They are 15, they are 19, who is getting them pregnant? And then you go to the judges like, okay, the practice here, parents are buying their children, they are giving them contraceptives. Condoms in young, we are giving contraceptives, but we are not going to the next question. So who are they going to have sex with? Because the mother is scared they'll get pregnant, so I'll give you this contraceptive and the like. But we are not moving the discussions as how they are supposed to be moving, because it must be comprehensive. It must start at the family level. What's really happening in society and what our roles like, because the adolescent will come to, she's already pregnant, but we want to prevent these pregnancies. So where are our gaps and how do we close them so that they can have a better quality of life, even for the children that they are giving birth to?
Thank you very much for those questions. Maybe I can start with the last one because it's quite elaborative. I would have said also, like those who have left, that the slides remitted that information, and I know from the part of the in-depth interview guide, there is that part of the question provided, whether they have knowledge about family planning. And that is actually where the gap is, because these adolescents are not exposed to the knowledge about the available family planning services. If you look around, you realize that the youth-friendly centers are not that functional, and that is where they need to have an access to learn about the family planning methods that are available. So I would say that the family planning methods are available, but they also don't visit to inquire about them. That is how they say it. They are not aware about them. And also, Daktari, these are a special population that will not consent for sex. So because they will never consent for that, we also give them an opportunity to learn about the family planning and also how to utilize them. I don't know whether I've been able to answer your question. For the healthy outcome, Dr. Jane asked about the healthy outcome. Yeah, this is a special population that also experiences obstetric and especially the obstetric complications because they are not developed. So from the sample that I was able to interview, apparently, I think it's like 1% who had a common one that is prematurity, but it is very common with them. Yeah. Thank you.
Thank you. Just, I think, one last general comment. In terms of your objectives, these are a little technical. The one you spoke about experiences, and then number 2 was how health services are responsive. When you look at the concept of responsiveness by WHO, it's actually experiences. So it will be experiences objective 1, experiences objective 2. So I think just look at how to frame the objective so that they don't appear like the same objective twice.
Thank you.
And then in terms of consent, I think in your discussion you might want to consider the aspect of Gillick competence, which allows that minors with capacity can still consent in especially matters of reproductive health. Thank you.
Thank you.
Thank you so much. Now, at this juncture, I've just gotten a notification. Daktari, just forgive me because of time. Yeah. So I've just gotten a notification from. Yes. Yeah. Thank you for that one wonderful presentation. Yeah. So I've just gotten a notification from catering that lunch is ready. So, ladies and gentlemen, I wish to take this opportunity to invite you for lunch. So lunch is served at the university cafeteria for all of us. So, Dean, do you have anything you want to add? So for our visitors who do not know where the university cafeteria is, you'll just use the cabros and you'll get there. But we have our colleagues who will guide you. We have some ushers who will guide you to where the cafeteria is. You're welcome for lunch. And please don't go away in the afternoon. We still have more presentations in the same room.
Thank you very much, Chair, for that wonderful guidance. Our listeners and members, we are taking our lunch at the cafeteria, but over lunch hour, we are requesting members of faculty and those who are interested in our research agenda at the school. We will be having one-on-one word with Professor Goodman, so please don't sit very far away. After taking our lunch, we can have a word over the lunch hour and then agree on a few things. Number 2, for our students from KMTC, this is your home. Please don't run away. Take notes. I know some of you will be joining us at our upgrading level. We have bachelors in upgrading for medical laboratory sciences, for nursing, for clinical medicine, for public health, at graduate level. So this is your home. So feel at home. Let's proceed to lunch. And more so those who have interest in health records or information, data science, big data, Prof is very much interested. We have already written a concept for the school on AI, artificial intelligence, and health. So he is working around those areas. Those who have interest in that area, please join us as we take lunch. By the time we come back here, maybe you could have exchanged the network and expand it. No, we don't have the venue. We will be meeting there as we hit. Yes, thank you.
So, ladies and gentlemen, you realized we started late after tea, so let us kindly get here as soon as we finish our lunch. Thank you.
Also, I recognize the presence of Dr. Kadhomi. Dr. Kadhomi, Professor Mochi knows her. She is here with us. She was the first one to register for this conference. Thank you, Dr. Kadhomi, for coming here. She is a public health expert, having worked with the Kenya Methodist University, widely traveled across the world. She has a lot to do also. Please, Dr. Kadhomi, be here in the front. Don't sit there. Thank you.
Okay, let's break for lunch, ladies and gentlemen, and let's get back here kindly as soon as we are done with lunch, so that we are able to. Yes, it's 2 o'clock. Can we give ourselves 45 minutes? It's 2 o'clock, so give ourselves 45 minutes. We'll be here at 2:45. We start immediately at 2:45, so that we are able to finish in time according to the program. So 2:45, we are starting. Thank you. Thank you. Let's break for lunch. Cafeteria is this way. You'll be our visitors will be guided. Oh, yeah.
the afternoon session. We are so much pressed of time and would want to give opportunity to all the presenters, if it were possible, so that they can have a moment to showcase what they have. So I won't make many remarks. What I would wish to say is that for those who are presenting, please make sure that your presentation is with us here, so that we don't take time transitioning from one presenter to the other. Again, for those who are presenting, we'll be timing you. Each presentation is going to take about 10 minutes. So our timekeeper is here. You'll be communicating, or will be communicating to you as you present, so that we're able to keep time. With those two remarks, I want to stop there and welcome the next presenter, so that she can take us through her presentation. Then we are changing the program just slightly to accommodate one of us, again, who is going to be present. After this presentation, we are going to have a presentation by a postgraduate student, Faith. Thank you.
Thank you so much for this opportunity. To be presenting the prevalence of E. coli and Pseudomonas on species on contamination of door handles in learning institution in Chiru area, Meru County, which is a project that I did, which is something that I did for my undergraduate project. So imagine you walk into a learning institution either as a parent and as a learner, and you need to use the washroom. I know you haven't thought about it, but think about the number of times you interact with that toilet door handle, whether it's you're getting into the toilet or you're leaving, or sometimes for parents, you're holding it for your kid. You probably haven't thought, it's very underestimated the power that, the amount of microorganisms that can be dwelling on that toilet door handles. So what my study aimed to see is what we aimed to see if we can find any contamination on door handles, specifically using E. coli and Pseudomonas, and what we were also checking for variability across several institutions. So door handles and knobs are amongst the most frequently touched surfaces in learning institution, making them hotspots for bacterial contamination. So in our case was Escherichia coli and Pseudomonas. These bacteria are of particular concern due to the ability to spread infection. For example, E. coli, it is known for common diseases amongst children. Pseudomonas in this case was used as an indicator for continuous contamination. Proper sanitation, regular disinfection, and hand hygiene are the most essential factors in ensuring that in minimizing the spread of these pathogens. So adopting strict hygiene protocols in learning institution can be used as a measure to reduce this contamination. approval from the MIREC. Involved collecting sterile swabs from the toilet door handles, and primarily we would culture the swabs on clade and maconchi agars. This is because both of the agars are differential agars that are specific for gram-negative organisms. We also did gram staining to ensure that whatever we are proceeding is gram-negative rods. After culturing, we proceeded to biochemical tests, one being TSI, where we expected, we were doing elimination method because we had 110 samples, which is rather a cumbersome sample size, so we were doing elimination method. For E. coli, what we were expecting is acid, gas positive, and hydrogen sulfide negative. For Pseudomonas species, we expected an alkaline acid reaction, gas negative, and hydrogen sulfide negative. For motility in indole and lysine agar, E. coli is known to be non-motile, lysine negative, but indole positive, which is usually the most, the indicative biochemical test for E. coli. For citrate, E. coli is negative, Pseudomonas is positive. So data collection questionnaires were administered to key informants to assess hygiene practices. So the key informants were the custodians, in this case custodians being the housekeepers in school and in the learning institution outside Meru University, Kunene Secondary and St. Tita Primary. The custodians in that case were teachers. The data presentation was done using pie charts, and data analysis was done using SPSS version 24. This was to establish the correlations between contamination levels and risk factors. The contamination rate was calculated using the formula, number of positive samples over the number of students multiplied by 100. So I'll use the graphs to demonstrate the results and findings. So for St. Tita Primary School, 40% of the samples collected tested positive for E. coli, and this shows the distribution between the contamination in female toilets and in male toilets, because all the samples were labeled whether they were collected from female toilets or male toilets. For secondary school, 20% of the total samples tested positive for E. coli, and for tertiary institution, our institution being Meru University, only 10% of the sample. Averagely, we had a total of 22.72 samples testing positive for E. coli, while we did not detect any samples of Pseudomonas. So 60% of the collected samples were from female toilets, which is quite alarming, while 40% were from male toilets. So the primary school indicated the highest level of contamination of 56%, 28% coming from the secondary school, and 16% coming from the tertiary institution. So the graph, as you can see, shows the different levels of contamination rates using the formula that I had illustrated. As you can see from described from the graph, there are different levels of, oh my God. Pardon? Okay, I'll just proceed. You can see that the primary school has the highest level of contamination rate. So risk factors, poor hygiene and rare cleaning practices, specifically from the door handles. Both Kunene, the primary school and the secondary school actually answered that they did not clean. They did not ever clean the toilet door handles. There was also the issue of the use of water only and not disinfectants or soap. Also, another issue was the students clean the toilets themselves.
2 minutes.
This is regardless of
2 minutes.
Okay. The weather now this giving in the factoring in that we did not know if the students were shown how to properly clean the toilets or not. There's also an issue of age, where young age results is equal to poor hygiene habits, the lack of soap and other necessary resources, and also gender seemed to be an issue. So the graph shows an inverse proportionality of contamination rates to hand washing and cleaning frequency, basically hygiene knowledge. So as you can see, the tertiary institution had the tertiary institution had the highest rate of cleaning practices, which contributed to a very low rate of contamination rate. While the primary school, very low cleaning practices in terms of knowledge and practices, but very high contamination rates. So results, the discussion, there was higher E. coli contamination in primary school, which is consistent with previous studies. Hygiene improving with education level, which is also consistent with previous studies. Female toilets having a higher usage, which contributes to higher contamination rates, and no pseudomonas, which was despite our expectations, which we can attribute to the timing of collection of the samples and also the period of the study. This suggests short-term and not persistent contamination. So in conclusion, the study established a significant presence of E. coli on toilet door handles in learning institutions, highlighting a significant risk of transmission of diseases through high-touch services. So we recommend education, in summary, we recommend education stakeholders and supporters to initiate programs of hand washing campaign, installation of important resources such as hand sanitizers and soaps, and enforcement of a cleaning routine, especially in primary schools. Thank you so much.
So thank you for that presentation. It's okay. That's it. So maybe we should give her some moment so she can respond to a few reactions before we continue. But let's give her a clap of appreciation for that very good presentation. Thank you. So any reactions? One or two reactions?
Thank you for a good presentation. Just a short one. That you did not get any pseudomonas, and you attribute this to the timing of the collections. Mm-hmm. So how serious was this effect on the validity of the results?
Probably you can say very serious, because also samples were collected around the same time. This was to reduce variability. So we normally collected the samples after tea break for the primary schools and the secondary schools. So in future, if the study if another study can be done to include sampling done at different times of the day and also at different seasons of the year. For example, we did our study at around March, which is rather hot in Tigania West. So if they do the same study around July, which we anticipate rain, we can probably find some different results, especially in regards to Pseudomonas.
Thank you. I also wanted to make a few comments. It's a good presentation. Probably you became very ambitious with the recommendations and conclusions. You had a very good study that if you stick to the results, you would have very nice findings. For example, when you say age and then you attribute it to primary, secondary, that is not age. If you just stuck to primary was more than secondary, because age is a different factor altogether. Number two, probably the prevalence is higher in females, because females have more toilets than was the sample 50-50, or you just went to the schools, picked all the knobs, and then, so you might find that the girls have more toilets than boys.
Okay, I'll just respond to the last part. According to the questionnaires, the principal of St. Rita highlighted it. She said that because boys tend to have urinals, they basically don't have more toilets, but girls, because of biological needs, they have more toilets. So basically that's a factor to also consider.
Okay, thank you. I request that we end that one there. Thank you, Zainab. May I welcome the next presenter, Faith, please. I want to believe we still have Ian around. Ian Modomi, are you around? Prepare. Okay, prepare. You coming next. Thank you.
Good afternoon, everyone. I'm Faith Kinya, MSc student. This is ongoing research work. My main study is to assess the determinants of health outcomes among patients attending Mare Teaching and Referral Hospital with traumatic brain injuries. But for today, I chose to present one objective, which is assessment of health outcomes, assessment of healthcare-related factors influencing health outcomes in traumatic brain injuries at Mare Teaching and Referral Hospital. Welcome. Okay. Traumatic brain injury is the destruction of the brain function, which is caused by a jolt or blow, or at times when one is involved in road traffic accident, and there is a mechanical force either which leads to acceleration or deceleration, and it brings about the dysfunction or destruction of the brain function, and it is the main cause of mobility, disability, and death worldwide. Globally, it's estimated that 69 million people acquire traumatic brain injury annually, and traumatic brain injury is higher in low and middle income countries, which is, the studies show that it's 3 times higher than high income countries. The incidence rate in sub-Saharan African countries is 801 cases per 100,000 inhabitants. In Kenya, traumatic brain injuries at mostly results from traffic road accidents. That is according to the study that was carried out by James et al. At Kenyatta National Hospital. For effective management of traumatic brain injury, it requires 3 standards guidelines that have to be followed at the end to. For effective management, the healthcare system ought to have reliable diagnostic imaging services, neurocritical care, and rehabilitation services. That is according to Center for Disease and Control in the year 2004. At Mare Teaching and Referral Hospital, there are challenges that are faced in meeting these standards, which are attributable to inadequate diagnostic services, neurocritical care, and rehabilitation services. The problem stressed meant traumatic brain injuries contribute significantly to mortality and disability, especially in low and income countries. At Meru Teaching and Referral Hospital, there is inadequate emergency response to patients that present to the facility with traumatic brain injuries. There is also no adequate neurosurgical care and rehabilitation services, which is more attributable to high work patient load at Meru Teaching and Referral Hospital, being the regional referral facility at the higher eastern region. And due to high rising cases, there is worsening of pressure on limited healthcare infrastructure. And also we find there is delays in care and also lack of protocols that are supposed to aid in the management of patients with traumatic brain injuries and impairing patient health outcome, which is also in relation to the study that was carried by Come and al. At Thika Level 5 Hospital in the year 2022. One of the research gaps identified that there is limited research evidence on how healthcare factors affect traumatic brain injury in Kenya. Sorry. The research objective is to assess healthcare-related factors that influence health outcomes of patients with traumatic brain injuries at Meru Teaching and Referral Hospital. The research questions what healthcare-related factors influence the health outcomes of patients with traumatic health injuries, and the scope of studies focused on healthcare providers that are directly involved in the care or management of the patient at Meru Teaching and Referral Hospital, and the study aimed to inform policy, evidence-based practice, and improve on care protocols.
You have 5 minutes left.
Okay. The literature review, the traumatic brain injury depends on trauma response, imaging, critical care unit accessibility, and rehabilitation services. In sub-Saharan Africa, we lack adequate neurosurgeons and functional CT scanners, which is in relation to the study done by Wereko in the year 2023. At Meru Teaching and Referral Hospital, there is only one CT scanner, which is often out of service, and there is only one neurosurgeon that serves over 2 million population. And also in Kenya, we find that according to the studies that have been done, one neurosurgeon is estimated to serve over 2 million people in Kenya. So, and therefore, these few studies assess how local hospital systems affect the health outcomes of traumatic brain injury patients. The study methodology, this is a quantitative method that was used, and the study design is the descriptive cross-sectional study design. The participants or the study population is healthcare providers. The total population was 992 healthcare providers. And then the Crobans formula was used to arrive to 75 healthcare providers. And then the 75 healthcare providers were administered questionnaires, of which 63 are the ones that responded. That's why you find the 63 there as the number. So the sampling method that we used was the stratified method, because there are various departments at Meru Teaching and Referral Hospital. So we used the stratified method of sampling so that we could get those departments that are involved in the management of TBI patient. Hence, random sampling was used to come up with the standard participants. The tools that were used is self-administered questionnaires that were administered to healthcare personnel. Data analysis is by descriptive and inferential statistics using SPSS version 27.
You have about 2 minutes left.
Okay. The response rate was 100%, and then 54.2% lacked TBI protocols, and only 22% of the respondents said that they always followed the protocols while managing the patient. 20.6% responded that the CT scan was always available, and 63.5% of the cases responded that the MRI was never available. There is a delay in surgery because of neurosurgeon shortages, represented by 77.8%, and also shortage of ICU beds as 74.6%. Equipment downtime and long queues was cited as the main challenge. That is the demographic and response rate. Reliability of the support services like the power supply and blood transfusion, the infrastructure and equipment. So the key findings: infrastructure was rated as fair or poor by 66.7% of the respondents. Rehabilitation services are available in only 50.8% of the responses. That there is inconsistent in adherence to protocols that are used in the management of TBI patients, that is GCS scale, the Brain Trauma Foundation guidelines, and ATL's guidelines.
The time is up. Just wrap up.
Okay. Then the staff shortages and protocol gaps are linked to poor patient health outcomes. My discussion is that the critical gaps cited are in infrastructure availability and adequacy, shortage of specialized healthcare providers like neurosurgeons, a lack of protocol adherence in management of TBI patient, high incidence of delays in surgical interventions and diagnostic imaging, and limited staff training on TBI care. In conclusion, TBI outcomes at Meru Teaching and Referral Hospital is affected by systemic healthcare gaps, shortages in neurosurgeons, rehab professionals, ICU beds, which compromise care. There is weak diagnosis and poor protocol adherence, which increases the complications of patient. Infrastructure and human resource deficits limit care quality, and strengthening hospital systems is critical. Recommendations is that there is need to have standard protocols which need to be implemented as per WHO guidelines, setting up rehabilitation units, and also in equipment to acquire modern CT scanners and MRI, and also in capacity building of the HR, so that there is recruitment and training of more neurosurgeons, trauma and emergency, and other specialists, and also integration of the policy into that's to include neurotrauma care in universal health coverage. Thank you.
Okay, thank you, Faith, for that presentation. I would request that we allow the next presenter to come to give their presentation. You have a question or some reaction to this work, you can note it down. We are going to open an opportunity to hear the reactions. So thank you.
Yeah.
Okay, Mr. Ian, take the stage.
Okay, my name is Ian. I'll be doing a presentation on assessment of select laboratory quality management essentials in hematology department at MTRH. I'll start by defining what laboratory quality management essentials are. These are procedures and guidelines that enable us to have quality results, which quality is defined by timeliness, accuracy, and consistency of results. According to ISO and Clinical Laboratory Standard Institutes, there are 12 quality management essentials. WHO has provided a checklist to examine the implementation of the laboratory quality management essentials. According to the WHO checklist, it has put more emphasis on 3 of the quality management essentials. That's process control, facility and safety and equipment management, which account to 172 of the 372 points, with process control having 71 points, facility and safety having 57, and equipment having 44. And hematology is a study of blood and related disorders. So this study will be focusing on process control, facility and safety and equipment management at MTRH. Problem statement. According to a laboratory mapping capacity report, it showed that the glaring gaps with with a maximum score of 4, or the process control, it was showing it to have 1.76 over 4, with Meru ranging between 1.0 to 1.51. For facility, a study by Bota showed that there were glaring gaps with 43 of labs lacking fire extinguisher, 19 lacking spill kits, and also for vaccination, you find that 34% of lab staff were unvaccinated. For equipment, there are also gaps with a national average of 1.01 over 4, with also Meru lagging behind, with some components of equipment management, such as calibration, having a score of 0.3 over 4, which shows we are doing poorly. For the justification, Meru was lagging even below the national average. You find like for process control, the national average was 1.76. For Meru was ranging between 1.01 to 1.51. Also, there was a lack of facility-specific essential data, so which we could not be able to do much improvement. Also, Meru lab is an accredited lab, but in the accreditation scope, in hematology, they have only accounted for blood count. They didn't account for coagulation, which is a critical component. The objective of the study will be to assess the selected laboratory quality management essentials in hematology at MTRH. The specific objective will be to describe the process control practices, investigate the adequacy of facility and safety measures, and describe the equipment management practices. The significance of this study will be able to assist the lab, the hematology department, to improve their performance. It will give patient confidence. It will also support the hospital in planning and in the accreditation, because accreditation is a sustained venture. It's not a one-time thing, and generally to improve the quality of diagnostic services in Meru Teaching and Referral Hospital. My conceptual framework will be checking the 3 essentials that I highlighted, with the process control having 27 sub-variables, safety and facility and safety having 24, and equipment having 16 sub-variables. That's basically those sub-variables for each essential. The study will be done at Meru Teaching and Referral Hospital. The study design is descriptive cross-sectional studies. The population will include the hematology lab, technologists, the pathologist, quality assurance officer, and the lab manager. I'll be doing a census because all those aspects, you can't separate each. You have to do all according to the checklist. You'll have to pass each and every sub-variables. I'll also use a WHO customized stepwise laboratory improvements towards accreditation checklist. Data collection will combine structured interviews, facility inspections, equipment evaluations to check for maintenance and calibration, and quality assurance review to check for control logs and training logs. Data will be prepared through SPSS, and also data analysis will be through frequency distribution, chi-square to check for consistency within the three essentials to see if there's significant difference. I'll be using the SPLPAT checklist and pre-administered piloting to minimize bias. Assumption will be independence of observation. 95% will be considered the optimum standard, the bare minimum, for compliance. Ethical will be sought from MIREC, NACOSTI, Meru County government, and participation will be voluntary. I think that's the end of my presentation.
Thank you, Bonayan, for that very good presentation. Let's appreciate him as he sits. Again, I would guide that we reserve reactions so that we have the next presenter. Then after the next presenter, we are going to have to receive reactions to the 3 presentations. So, welcome, sir.
So, I'm Vincent Mukundi Gitonga. I'm taking MSc in Public Health. My title is Assessment of the Role of Community Health Promoters in Hypertension Care in Meru County. So, a community health promoter is defined as a personnel who is usually selected by the community, appointed by the county, and also paid by the county. They are usually assigned a certain group of homestays in a certain region. And their work is to do screening on non-communicable diseases like hypertension and diabetes. Hypertension is defined as a chronic condition which is usually asymptomatic, and it is dubbed as a silent killer since most of the people do not realize any symptoms that direct them that they are sick or they need to seek medical assistance. So during routine checkups, that's when most of the people find that they have it. So community health promoters are set in the community, and they usually do routine checkups, hence enhancing their clients to know or to be able to realize that they have the problem and seek medical attention. In Imenti North Sub-County, we have approximately 3,616 people who have the disease, with that 2.5% of them facing challenges in adherence. And so the study aims to investigate on the role of these community health promoters and how they can be utilized to enhance, improve care, hypertension care. So on problem statement, we find that only 3%, we only have 3% of the healthcare workforce operating in sub-Saharan Africa, where 24% of 24% is covered by the community health promoters, despite the challenges that they face and the heavy workload that they face. In Imenti North, we find that there is a problem with the adherence, as I've said earlier, of around that 2.5%. And this comes about because of certain problems, like most of the people do not get access to medication. Some of them forget, others are in denial state. They don't accept that they have the disease. Others do not like the taste of the drugs. Others do not like the side effects that come up after taking the drugs. So my main objective is to investigate the role of community health promoters in hypertension care in Imenti North Sub-County, with the specific objective being to analyze the prevalence of hypertensive patients under the care of community health promoters in Meru County. The other objective is to examine the availability and utilization of blood pressure monitoring tools used by CHPs. The third one is to determine the effectiveness of community health promoters in supporting adherence to hypertensive treatment in Imenti North Sub-County. And the last one is to examine the challenges that community health promoters face while administering their services. Justification. Hypertension in Imenti North is a public health issue. As I said earlier, coming up to that 2.5% of non-adherence, that is according to Mwenda et al. 2021. Community health promoters are vital in this because they do screening, they boost adherence by doing follow-up and home visits. Bearing in mind that uncontrolled hypertension poses a great risk of complications. Some may complicate to heart diseases, and others may end up getting stroke and even death sometimes.
You have 5 minutes to go.
Okay, so the study aims to strengthen and cover up the gap on the CHP practices, and also improve and also sensitize the policymakers on to better understand their role and incorporate them in while making policies. My conceptual framework, as you can see it, it's covering the 4 independent variables. They have the sub-variables, and if followed up, if we implement them, then the result will be on the independent variable, where we'll have improved hypertension care by CHPs. Yes, to go to methodology, the study area will be Imenti North Sub-County. We'll use a descriptive cross-sectional study design. Study population will be community health promoters working in Imenti North Sub-County. Sampling methods. The study proposes to employ a simple random sampling. The sample size will be 208, that will be derived from the population of 450 community health promoters who are in Imenti North Sub-County. And we will come up with the 208, the sample size, by using the Cochrane's finite formula. Research instrument will be a structured questionnaire. Data collection to be collected using the structured questionnaire. sampling procedure. The researcher will attend monthly community health promoters meetings that are usually held on monthly basis, and that's where the questionnaires will be administered. Data preparation will be through systematic SPSS, data analysis, descriptive statistics will analyze. We'll summarize standard variables, while logistic, regression, and chi-square test will assess the relationship. Data presentation will be through tables, graphs, and charts. We will minimize bias by doing a pilot test. And ethical consideration will be sought from MILEC, and voluntary participation will be allowed. Thank you.
All right, thank you for that very good presentation. Let's appreciate him again as he sits down. This is a very relevant topic, issues that we are handling every other day. So at this juncture, I would wish to invite reactions. Those are 3 presentations. Well, this one is still on there. If you have any reactions to the 3 presentations that we have had, probably we can bring in those reactions. Okay.
Thank you for the presenters. I have probably some observations, especially in the presentation. The next presenters, please don't take so long on the background and all the others, and then you rush through the results, because we are here for the results. We're here for the results. So just rush through the background and then let us know what you found out. For the first presenter, just a comment that your data, your literature review came all through, like we could tell the results of your study from your background. So I would suggest that you leave the literature review to your results if your results agrees with the literature review, so that you link it there. Because if you link it before, then it will run all through. We already know the results. For this one, the proposal, I have a problem with the first objective, just to mention the prevalence rate of hypertension patients under the community. I don't know how you're going to get the prevalence rate. Even in your conceptual framework, we don't see how the prevalence rate is going to improve the outcome of patient care, especially in hypertension. Thank you.
Sorry. Thank you for those reactions.
Thank you very much, especially Mr. Gitonga, the last presentation. I think I'm concerned about the last presentation because NCD is a very important condition. Now, I think the title is about the role of CHWs, and I think I would like you to refer to 3 documents that might be useful for your reference. The Community Health Strategy 2020-2025. Kenya Community Health Policy 2020-2030, and NCD module for this particular group of people. Now, my point is that if you investigate the role, I do not see the significance of that, because in their training, in their module on NCD, on page 49 of the module, unit 3, they actually cover hypertension. So the roles are well stipulated. I think what might be more useful is for you to evaluate the extent to which they perform their roles, because the roles are still well stipulated by the policy, the government policies, and you can read about NCD module 13 So you cannot investigate the ROs because the ROs are already stipulated, but you can evaluate the extent to which they perform the ROs and perhaps the potential reasons why they don't perform the way they should perform. That way then you can make recommendations about the implementation aspect of that particular CHP program that is not being implemented the way it should be because they have been trained but they are not performing the way they should be able to perform. Thank you.
Thank you. There is some reaction in front here.
Maybe for the first presenter on the traumatic brain injury, it is important that you also look at the patient-related factors as a recommendation, because the outcome will also depend on the time the patient is referred to the hospital, and again, more important, the means of coming to the hospital. A patient coming in a wheelbarrow may be more traumatized than that who came in an ambulance. Thank you.
All right, thank you. Any reaction? Do you want to respond to those reactions, Faith? Okay. I hear none that is directed to you, Bwana Ian. Okay.
Okay, to respond to incorporating the patient-related factors, as I said that it's an ongoing research work. I have that as my objective. I've already looked on the patient-related factors, types and prevalence of TBIs, and health outcomes. So that one is incorporated in the research work.
Thank you. I think we stop there with the reactions. I'm observing to see that we have not logged a valuable reaction so that we can improve on the work, because what we have had is work in progress. If none, then I wish to invite the next presenter, who is supposed to take us through their presentation. Do we have Meritho Julius? Okay. Then he is going to be followed by Monica Maina. I want to believe you're with us. Bring your presentation if it is not here yet, but we believe they are here, so prepare. Thank you.
Good afternoon, ladies and gentlemen. My name is Julius Kinyeli Meretho, master's student. I'm pleased to take you through the program. This was an evaluation of access to prosthetic and orthotic devices for trauma and injury interventions in rehabilitative health care facilities in Meru County. This one, my supervisors were Professor Mutema, Professor Muchiri, and Dr. Kubai. Okay. As you can see, according to the background information, yes, according to the WHO report on disability 2011, more than 1 billion people in the world live with some form of disability. It also predicts that a number of devices needed will increase globally in 2035. Prosthetic and orthotic devices are assistive devices that maintain or improve an individual's functioning and independence and enhance overall well-being in the society. They also prevent impairments or secondary health conditions and enable persons with disabilities to achieve personal mobility. Rehabilitation refers to helping a person who has suffered illness or injury restore back the skills and regain maximum efficiency, and it enables regaining physical, mental, and cognitive capabilities that have been lost or impaired. Rehabilitation services mostly provided through prosthetic and orthotic devices help people to return to life, to daily life, and live a normal and or near normal life. A review of medical data in Mero shows non-existence of data of persons in need of prosthetic or orthotic devices, and subsequent rehabilitation services limited in majority of health care facilities. Therefore, there is a need to improve access to prosthetic and orthotic services across different health facilities. Problem statement. WHO predicts that the number of people in need of assistive devices globally will increase beyond 2 billion by the year 2050. It is further expected that disabilities will increase across the world due to a surge in aging populations, as well as global increase in chronic diseases such as diabetes, cardiovascular disease, cancer, associated trauma and injuries, according to WHO 2011. Disability is one of the most serious impairments that affects people and make them unable to be fully productive. People with disabilities have poor health conditions, low education achievements, less economic participation, and higher rate of poverty than people without disabilities. According to Agrochemical 2017, information is needed to form the operation and management level plans for effective implementation of WHO prosthetic and orthotic standards. This study, therefore, aimed at evaluating access to prosthetic and orthotic devices and the services offered for trauma and injury interventions in rehabilitative health care services in Meru County. Research aim and specific objectives. The main objective of the study was to evaluate access to prosthetic and orthotic devices for trauma and injury interventions in rehabilitative health care facilities in Meru County. The first objective was to determine the types of prosthetic devices offered. The second was to determine the availability of prosthetic and orthotic devices, also to determine the level of provision of the standards and guidelines according to the world standards required, and then to determine the obstacles encountered in the process of provision of the prosthetic and orthotic devices. Justification. It is estimated that worldwide approximately 1.5 million disabled people in low-income countries like Kenya require effective rehabilitation health care services by the year 2035. The United Nations Convention on Rights of Persons with Disabilities defines the frameworks for prosthetics and orthotic services, and Kenya is a signatory of these conventions. The study assessed the current state of prosthetic and orthotic services offered in Meru County health facilities and evaluated the effectiveness. Further, the study will inform health managers and the level of implementation of frameworks and the standards that ought to be followed in providing rehabilitation services. The significance of the study was to provide information on rehabilitative services in the county and the law and how to assess prosthetic and orthotic services can be improved in view of increasing trauma. You see the trauma and the injuries are increasing daily due to, technological development like motorcycles, all that. and these lifestyle diseases like diabetes. So every day people are being amputated, people are being injured. So you need these devices to rehabilitate these people. The study was limited to data collected from respondents as such. The respondents' feelings, attitudes, and failure to respond to certain items in the questionnaire may not affect the consequences. The study focused on main stakeholders, including orthopedic service providers, patients, healthcare workers involved in either directly or indirectly in the provision of prosthetic and orthotic devices. The patients also guidance and clarification for better clarity addressing and answering questions in the questionnaire. Assumptions. The study assumption was that sample chosen was representative of the target population and the participants were voluntarily given objective information for the study. The study assumed that interviews and responses by the respondents offered gains and shortfalls for prosthetic services. All these are there strictly to the ethical standards and guidelines to hold to be upheld conducting the research. Literature review. Evaluation is a process of assessing, testing, measuring, and verbal judgment of level performance and achievement. It's mainly composed of 4 stages: planning, implementation. This is what we call CIPP. There are various models, theoretical models of evaluating, but I chose one CIPP model: context, input, process, and product, which are used in evaluating.
2 minutes to go.
2 minutes. So those out of the 4 models, I chose CIPP, which is the most effective theoretical framework. Prosthetics refers to the use of artificial limbs. Orthotics refers to fitting a supportive appliance to a weak limb. Theoretical devices, you can see. Literature review was done through the world standards, frameworks, ISPO, International Site for Prosthetics, National Council, and the Constitution of Kenya. So you can see the...
Just move to the results. Just move to the results, that at least you have a glimpse of the results.
The study identified the types of prosthetic and orthotic appliances applied in the Meru County with the transfemoral prosthetics. Transfemoral means through the arm, with 34.2% being the highest used for hyperprosthesis. For the lower limb, 27% was the highest, and the findings for the orthosis are supportive appliances. 57.8% was for the AFO, below the elbow, below the ankle joint. These findings are consistent with the global events where lower limb orthotics and prosthetics are more common due to higher rates of lower limb amputation and injury, according to Smith, 2018. The occasional provision of partial limb, partial hand, and hemipelvectomy prosthesis suggests an absence of provision of solutions for complicated cases, which is consistent with the literature in low-income settings and the documents in the absence of specially devices, 2015 by West. Provision of orthotic devices in Meru County was very low, with the 68% of the respondents reporting services are not available. These findings are consistent with the findings in the low and the middle income countries, where resources and availability limits rehabilitation equipment provision. The positive correlation between education level and perceived availability shows that highly educated employees may better use shortcomings in service, an effect found in the research in rehabilitation where training affects perception. Results and conclusion discussion. Utilization of orthotic and orthotic devices standards and guidelines in Meru County was low, 71% respondents indicated. These findings are consistent with research citing the lack of standardized protocols in low-income countries. Rehabilitation centers, as a study was done in Nigeria. The significant relationship between age and perceived provision, Chi-square 222, indicates that older respondents, possibly with longer exposure, perceive adherence, a pattern found in studies where seniority associated with optimism about system capabilities. That's according to Chandran 2020. Quickly, I will go to conclusions. The study reviews alarming deficiencies in the delivery of prosthetic and orthotic services in rehabilitation facilities in Meru County. Where there are different devices available, the delivery is significantly reduced with extensive gaps in clinical, physical, and fabrication services. Adherence to standards and guidelines is extremely low, undermining the quality of care. This is very critical. That's why I did this research. Contrary, barriers were reported to be few, which was indicated under reporting or normalization of prevailing systemic issues. These findings show that there is an immediate need for systemic improvement to promote the accessibility and the quality of orthotic and prosthetic services to patients with trauma and injury in Meru County. Recommendations. Sorry. This recommendation is to enhance availability of devices, to enhance standards and guidelines, to improve training and sensitization, restore, refund, and psychosocial support, conduct further research according to long-term outcomes and patient perceptions. Some references. Thank you.
Thank you. Bwana Merito, I recognize that your supervisor, at least one of your supervisors is in the house. Probably we'll give you an opportunity to hear some reactions. I will invite the next presenter so that we're able to hear another presentation. Sorry. So please note down the reaction that you may have had for Bwana Miredo, then we are going to invite him again so that we can give him some reactions. Thank you.
Okay, good afternoon. I'm Monica Maina, a master's student in public health. I'm presenting the study that I will be doing on evaluating the effectiveness of Linda Mama healthcare program in maternal health outcomes in Nyambene Sub-County Hospital. My supervisors are Zachary Muroki, Mary Amatu, and Patrick Kubai. On the background of study, Linda Mama provides an affordable maternal health care in Kenya, thus reducing financial barriers and ensuring quality of care. That is the Auditor General Report of 2022. Linda Mama program was launched in 2013 under NHIF, that was scrapped off in 2024, but now it is under social health Authority and under the Social Health Insurance Fund, the SHIF and the SHAT that we are using right now, that is according to the Ministry of Health 2025 report, which, and with the research done by Orangi et al., it is stated that enhances maternal health care access and transparency. On Nyambene Sub-County Hospital, where I will be doing my study, the deliveries at 6,000 births that was reported in 2022 and 5,700 in 2023. That is about 17.5% of the Meru County totals. This was got from the Kenya National Bureau of Statistics of 2024 report. This study assesses Linda Mama effectiveness at Nyambene Sub-County Hospital, which will focus on the service use, that is the utilization, the obstetric complication, the mortality, and the care satisfaction on the quality of care by the mothers. On the problem statement, in Kenya, we have 2% of women that lack access to skilled antenatal care, with Meru County was slightly better at 0.8%, yet only 29% nationally that had started ANC in the first trimester. On the postnatal care gaps, it persists with 20% of the Kenyan women and the 35.2% in Meru receiving no checkup within 41 days of post-delivery. That means the Linda Mama covers the mother before delivery, during delivery, and postnatally. That is the first 6 weeks of life for the newborn. This report was got from the Kenya National Bureau of Statistics. On the obstetric complication that will base my second objective, it was led by hemorrhage, whereby we will focus on the antepartum hemorrhage and postpartum hemorrhage, where this research was done. About 1,181 cases had hemorrhage. The contributory factors, those are the complications on obstetric complication, that is the prolonged labor. There were about 552 cases. On the Kenyan maternal mortality rate, we are at 355 for 100,000 live birth, with Meru County at 300 per 100,000 live birth, despite the Linda Mama being in existence. That is according to the Kenya National Bureau of Statistics of 2022. Limited research has been done, and facility-specific data has aimed at understanding of the program effectiveness. That is why I settled at Nyambene Sub-County Hospital. On the objective, my main objective will be to investigate the effectiveness of the Linda Mama Healthcare Program in maternal health outcomes at Nyambene Sub-County Hospital. On the specific objective, I will examine the utilization of the maternal health care services, I'll analyze the incidence of the obstetric complication, I'll analyze maternal mortality among women receiving the services through the Linda Mama program, and the fourth one, I will investigate beneficiary satisfaction levels with the quality of care. On the justification of the study, due to high maternal mortality rates in Kenya, which stands at 355, and Meru at 300, and there is also low antenatal and postnatal utilization, highlights the urgent need to evaluate Linda Mama program impact. The research is critical to address obstetric complication, and this inform intervention to achieve the standard development goal number 3, with one of its main goal is to reduce maternal and child mortality. Meru County is in a rural setup context that shows persistent gaps in antenatal care, whereby 8.2% had one visit of the antenatal clinic, while 35.2% had no checkup postnatally. There is also high home deliveries at 5.9, despite the Linda Mama program being in existence. Nyambene Sub-County Hospital records high volumes of delivery compared to other facilities in Meru County. On the significance of this study, it will drive improvement in maternal health care access and complication management. It will mortality reduction. It will also offer evidence to enhance the Linda Mama program. It will also empower local healthcare system and inform policy reforms to contribute to achieving equitable, high-quality maternal care in alignment with the Global Health Sustainable Development Goal number 3. On the conceptual framework, the independent variable will look at my objective, the utilization of the service, that is at the ANC level, at the delivery service, postnatal care services. On the incidence of obstetric complication, we'll be looking at hemorrhage, preeclampsia that is common, and also infection. On the maternal mortality, there will be maternal mortality rate, the cause of death, and the timing of death. Is it before, at delivery, or after delivery? We'll also evaluate on the beneficial satisfaction, that is the provider attitude, the service availability, and the resource availability. On the dependent variable, that is the effectiveness of Linda Mama program, we look at improved maternal health, reduced maternal morbidity, enhanced service satisfaction. The study sites will be at Nyambene Sub-County Hospital to use descriptive cross-sectional study. The study population will be multiparous mothers and the health records officers that will help me in getting the mortality rates from the files and the records reported earlier. So use simple random sampling of a sample size of about 178 multiparous mothers. The research instruments will be customized structured questionnaire. The data collection procedure will propose a training research assistance, securing informed consent from the eligible participant, administering the questionnaire, and recording data over 2 to 3 months. The data preparation will be systematic, SPSS data management. Data analysis will be frequency distribution, and chi-square will measure statistical significance. On the minimization of bias, there will be random selection of multiparous mothers and anonymity of participant and privacy. So we'll assume an independence of observation. I'll seek clearance from the MIREC and the Meru County government. The participation will be voluntary, where the participant will be informed of the research beforehand. Thank you.
Thank you, Monica. I'm also being reminded to look at my watch. Time is far much gone. And for that reason, probably we should just invite the next presenter. So at least we have another one more presentation. Then after that, we see how we move forward. So the next person on line is Monica. Are you with us? Yes? Oh, okay, fine. We have Monica Mine and we have Monica K. Yes. Yes, by coincidence we have Monica and Monica. If you can be able to do the presentation in less than 10 minutes, then that will be very good for us. Thank you. Welcome.
Thank you.
Good afternoon. Okay, my name is Monica Kiraki. I'm presenting one of the objectives of an ongoing PhD study with 5 other objectives. So this is a part of the basic or the starting point. That's the baseline study that was looking at the assessment of psychosocial needs of patients with prostate cancer attending Meru and Embu cancer centers. I want to appreciate my supervisors, that is Dr. Catherine Gishunge and Dr. Kome Impwe, both of Chuka University. So the promotion of health behavior and the management of emotional well-being can be achieved through the psychosocial support. And this is the support that is provided to meet the spiritual, emotional, and mental well-being of a person who is ailing, a community, or even the family. It can be used in long-term for the long-term conditions such as cancer, depression, HIV, among other conditions. And so it is recommended in the management of cancer care to increase the scope of cancer management. However, there is a big gap in the high prevalence of cancer in the sub-Saharan Africa and the availability of psychosocial and educational interventions among cancer adults. Furthermore, there are some studies in Kenya, that is one in Meru and the other one in Machakos, that have shown that there is a need for psychosocial support because the patients have concerns, psychosocial concerns such as worry, areas of eating, pain management, financial constraints, fatigue, among others. That is according to Gitonga and Kinoti in 2021 and 2020. So the Ministry of Health, through the cancer management guidelines, have recommended the incorporation of psychosocial support. However, there is minimal utilization of the same, and this is specifically among men. And the specific reason why we chose to concentrate on prostate cancer, it is because prostate cancer is one of the prevalent cancers among males, both locally and globally. That is why we focused on that. So this, as I have said, is a pre-intervention study. And so the aim was to identify the psychosocial needs of patients with prostate cancer attending those 2 cancer centers. It was a descriptive cross-sectional study, as I've said, in Meru and Embu cancer centers, targeting the patients with prostate cancer. Since it was an interventional study, that's why the sample size may look small, 58, that was sampled through simple random sampling using the cancer registers, and that was obtained. The pre-testing had been done in Nyeri Cancer Center so that we could minimize the risk of contamination and also to ensure that they are not part of the participants in the other 2 facilities. Data was obtained using a structured questionnaire. That questionnaire had a tool attached to it, that is comprehensive needs assessment tool. And since it was a mixed method approach of data collection, we had both quantitative and the qualitative. Qualitative was obtained through focus group discussions. Data was analyzed using statistical package of social sciences and en vivo for the qualitative. The ethical clearances and permits were obtained from the Chuka Institution Ethical Review Committee, NACOSTI permit. The referral hospitals, some have ethical committee sitting again, which approved the study. And also the in charges of the cancer centers gave permission to collect the data, and the participants signed consent. So the mean age of the participants was 72 years. Most of them were between the ages of 60 to 74. Majority were married, and most had secondary education and above. We had more of them being Protestants, and we had a high number that is not employed. And looking at the age, the range of the ages, that is well understood. And then somehow low levels of income, and all of them had a medical cover. And the most prevalent type of medical cover is the one that we are currently using, the Social Health Authority. And those are the counties that the participants came from. Most of them are from Meru County, The other one were from Embu County, and this is because probably it's the local environment of where the cancer centers are located. In terms of duration of illness, most had been ill for 27 months, that is around 28 months, most in 1 to 2 years. Majority were diagnosed of the disease while at stage 3, so there is a late presentation of the patients for diagnosis. Chemotherapy was the most prevalent mode of treatment was being used. Most didn't have any other comorbid, and for them that had, hypertension was the most prevalent. The tool had different aspects. The comprehensive needs assessment tool had different aspects on the results of the needs. The healthcare staff needs were the most prevalent. It had 8 points. It was followed by the family and the information needs. Those are the areas that had the most high needs of the patients. In terms of the level of the needs that were classified after obtaining the means per item, per individual, most of them had low level of psychosocial needs. When it came to the qualitative data, in terms of healthcare staff, the patients needed that the healthcare providers to be empathetic, to be respectful, to explain the treatment, and prompt response when they come for the treatment. In terms of information, they needed proper guidance after diagnosis. What is the expected treatment side effects, self-care at home, what can they do at home when they have the disease? Recognition of signs and symptoms, some were saying that they need to know what would make them rush for treatment and what can wait. It's not an emergency. They also needed appropriate diet for the disease and what are the services they can use later in life, that is the hospice services. For the family and social support, they needed to know how they would continue to maintain their relationships with friends and family, maintaining intimacy for them that were married, and emotional support from the family. Psychosocial, they needed how to deal with anger, depression, anxiety, guilt, and fear. For the spiritual needs, they also needed to know how they can reconcile with their faith after the diagnosis. Some also say that spiritual aspect provided comfort to them. It's a chance of peace and surrender that they can be able to channel those things through the spiritual aspect. The practical needs, they complained of long distances from where they are living to come to the cancer centers. They also needed support from family and friends. They also needed some financial support for the family and also to take care of the treatment. Hospital facility and services, they complained of delay in initiating treatment. They also want consistent counseling services. Some felt lost and supported after the diagnosis. They also need follow-up at home, peer support group where they can interact with their colleagues who are sick. And they also want incorporation of the family caregivers in the treatment. Therefore, the researcher recommends that the targeted psychosocial support should focus on enhancing involvement from the healthcare providers, improving information dissemination, and strengthening family and social support. Those were the most prevalent areas that had the needs. And for research, it is good to find out what are the factors associated with the psychosocial support, psychosocial needs, and also to determine if these needs are in any way related to the health quality of life, which is part of the continuation of what the researcher is doing with this work. Thank you.
Thank you for that very good presentation. I wish that probably you just maintain your position there so that we invite 1 or 2 reactions to this presentation before we carry on. Any reactions to what has been presented last? Okay, there is none, apparently, only one.
Hello,
I'd like to ask a question. Your study only focused on people who opted for hospice for treatment at cancer centers. How about those who opted for hospice care? Did you consider that as a factor?
If you look at the Kenyan aspect of cancer management, for hospice care is more of the palliative. That is the end part of the journey. But now you wanted to see from the early diagnosis, those that could be found now in the cancer centers all the way. So that is why it's specifically focused on the cancer centers rather than going to the hospice. And part of the foundations of this study was from hospice. So it's building up from some other levels.
Fine, thank you. Apparently, there's no other reaction. So I'm guided that we should just carry on. So let's appreciate her as she takes her seat. Yes, just before my colleague comes to make some remark, let's charge ourselves to continue just a little bit so that we have two more presentations before we can close the day. With a lot of consideration, we just need to give the others an opportunity. Let's hear what they have. Thank you.
Yeah, I want to make one or two observations. That why we are not getting this on time is that we have found that some slides are very congested. Where we find a bullet as 6 sentences, that cannot be Microsoft PowerPoint. That is something that we take a lot of time. The other thing we observe is that you need to catch your audience eye. If you are gluing your eye onto a laptop, then we think you do not know your stuff. So please let us catch your eye and let us so that we can even move far much faster. Thank you.
All right, thank you. So because of the pressure we have with time, would request that for the next presenters who are coming, please, the audience get or note down your reactions. We are going to collect all these ones and they can be directed to the respective presenters so that we don't provide a time for discussion in between. We just have the presentations moving one after another. So the next presenter is supposed to be Lekilit Jacob. Are you in? Okay, fine. Please come forward so that you can share with us your presentation. After this, we are going to have Amos Mutinda. Amos? Amos? Okay, fine. I can't see Amos around. So in that case, then we are going to move to the next presenter, Lynette Makandi. Lynette Makandi? Oh, okay, fine. So prepare. After Jacob, you're going to come. So like I said, Jacob, if you can go to do a presentation in less than 10 minutes, the better it is for us.
Good evening.
Yes, you advised that if you avoid much of the preliminaries, the background, the literature, just highlight the key things, then give us the other
Good
key
evening.
stuff. Thank you.
Welcome to evening sessions. I'm Lekilit Jacob. I MNC Public Health second year. I'm here to present the proposal. Yeah. So the assessment of mental health inequalities and access to mental health services in Samburu East Sub-County. My supervisor is Dr. Kubai and Dr. Mary Joy. Mental health is overall well-being of individual in all aspects of life. So basically, mental health has many definitions, but according to WHO, is just how we handle our emotions psychologically and how we handle our stresses in normal days life. Mental health is a critical component of overall being, yet it remains a significant under address in many parts of the world, particularly in low source settings. So mental health affects many people and communities globally, more so underserved community according to Vigo ATL 2020. In Kenya, it is ranked number 4 in Africa due to prevalence of mental health, and the leading counties, as we know, we have 47 counties. Nairobi is the leading county, and Samburu County is part of the Kenya, and the prevalence rate of mental health in Samburu County is 25.4% according to Kenya Commission of Human Rights study that was done in 2022. So there is a lot of challenges as per the previous studies that was done, and the region isolation. Yes. Okay. So the study aimed to explore the status of mental health inequalities in Samburu East sub-county by focusing the prevalence of selected mental health illnesses. By understanding dynamics, the research seeks to inform interventions that can address this disparity and improve mental health outcome in the county or marginalized community. Problem statement: mental health disorders are currently increasingly recognized as a critical public health concern, as I have said, worldwide. As you can see now in the previous study that was done, WHO, you find that it's approximation of 1.9 billion people affected by mental health illnesses. Africa, if you see in Africa, you find that it's 1.9 million people affected in mental health illnesses. And that's why we have high incidence of mental health disorders among adolescents in sub-Saharan countries with lower. Communities in counties that are affected include the Maralal community, Baragoi, Achas Post, Rodosoit, Southor, and Kisima. Despite the growing recognition of mental health as a vital component of overall well-being, there is limited data on the types of mental health disorder prevalent in Samburu sub-county. The knowledge gap embeds for formulation of target interventions and policy aim at addressing mental health needs in the region. Justification: mental health disorders are increasingly recognized as a significant public health issue in Kenya, yet this remains a dark gap in access to mental health services, particularly in rural and underserved regions like Samburu sub-county. Despite the global and national effort to address mental health disparities in the availability and quality of mental health services, persistence, often exacerbated by social, economic, cultural, and healthcare. So with a global recognition, we have problem management plus an initiative that is driven by WHO, and currently now we are implementing in Samburu East, especially in Samburu North sub-county, and interventions used to prevent the mental health issues. My main objective to investigate the current state of mental health inequalities and access to mental health services in Samburu East sub-county. Specific objective to determine the types of selected mental health disorders prevalent in Samburu East sub-county. Identify social economic factors influencing mental health disorders. Third objective is identify social cultural factors contributing to mental health disorders in Samburu East sub-county in Kenya. Then the fourth objective to determine health factors contributing to mental health. My research question is what are the types of selected mental health are prevalent in Samburu East sub-county, the social economical factors that influence mental health, then we have also the cultural factors and healthcare factors. The study area will be Samburu East Sub-County, and is characterized by the pastoralism community, the predominant, and mostly they are farmers. Then the study design will use descriptive cross-sectional studies with sequential mixed method, whereby you will use the qualitative and quantitative approach to provide comprehensive understanding of mental health inequalities and access to mental health care services. The study population, the resident of Samburu East Sub-County. Methodology, are the resident of Samburu East, then individual are presented or diagnosed with the suspected symptoms of mental health disorders, including but not limited to depression, anxiety, bipolar disorder, schizophrenia, and substance use disorder. Inclusion criteria: individual below the 18 years, non-resident of Samburu East, and individual with non-mental health or related medical conditions. Then those are my study variables: independent types of mental health, social, economical factors, cultural factors, and healthcare factors. Then independent variables will be mental health inequalities, then prevalence of mental health disorders. Sampling techniques will be random sampling techniques and ensure presentation across different demographic. The methodology, data collection method, it will be survey will be used to collect primary data from the respondent using structure questionnaire, and again using key formats, data collection instrument, structure questionnaire, key format interviews, and focus group discussion. Validity will be done away from the study area, and then the strategy to achieve validity and reliability will include the training research resistance before the study, standardize of data collection tools. Data will be analyzed using the Excel, and SPSS will be used to handle data analysis. Those are my ethical review to seek the approval from Mary University of Science and Technology and county health offices and MEREC. And this is my roadmap of my work plan. Estimated budget. Thank you.
All right, thank you. Thank you, Jacob. Like we said, we want to move a little bit faster. I ask that we appreciate him so that he takes his seat. Then the next presenter comes. Thank you so much. So we wanted to confirm whether Bosibori Janet is in. I'm told she could have made a presentation elsewhere. Are you in, Janet? Okay, she's not here. So in that case, then we'll give Purity Kadhambi the next opportunity. Thank you. You're most welcome. You can take us through your presentation.
Okay, thank you. My name is Getuma Lynette Makandi, a first year Master's Epidemiology student. I'll be taking you through the genetic predisposition to non-communicable diseases. As you've heard, a number of presenters here have mentioned hypertension, cancers, mental health. All those are part of the non-communicable diseases. And as you have heard, they are a public health concern. And on the overview of the NCDs, the non-communicable diseases are the leading causes of deaths globally, with WHO statistics showing that there are around 43 million people, with the 75% of non-pandemic related deaths occurring in 2021, 18 million of those deaths occurring in less than 70 years, and 82% of the deaths occurred in the low and middle income countries. In Africa, in 2019, NCDs were responsible for approximately 37% of all deaths in sub-Saharan Africa, a sharp rise from 2000 to a sharp rise from 24% in 2000. This CDC Africa shows that 24 million are affected and is expected to double 46% of adults and is the highest in the world. That is why genetics, when you go to study, we analyze the genetics and how they lead to the development of these NCDs. We can be able to come up or predict the risks and help prevent these occurrences, at least reducing the burden. As you've heard, even the rehabilitation, we need to cap that. The relevance of this topic is that in incorporating genetics in the healthcare system, it will help reduce the disease burden due to early detection, specific targeted management, and lifestyle changes. It will also involve precision medicine, which is personalized, it's preventive, it's predictive, and participatory medicine based on the individual's genetic makeup, the environment, and the lifestyle. It will also help in pharmacogenomics, where the drugs are used depending on the person's genetic makeup, reducing the side effects and the reactions. And as you know, there are so many innovations currently due to the technological development, like the artificial intelligence, machine learning, mobile health, where you can use the apps to monitor the objectives to assess the published evidence on genetic predisposition to NCDs, to explore the genetic research related to NCDs conducted in Africa, and to understand the role of genetic research in prevention, diagnosis, and management of NCDs. The methodology I used, since I was just doing a systematic review with the aim of coming up with a proposal, I used the qualitative analytical methods. The inclusion criteria was based on the generic research in Africa, genetic research in Africa, and only those that were written in English. I excluded all non-English articles as well as those outside Africa, with the key words used being the genetic predispositions, NCDs in Africa. The findings that I came across were that there is evidence of genetics being a contributing factor. For example, for breast cancers, we have the BRCA1 and 2, according to the National Cancer Institute 2024. There is also genetic susceptibility, which plays a pivotal role. And Murrell et al. 2023 shows that genetics are important in optimizing treatment, prediction of risk, and support in prevention of NCDs. The common and communicable diseases, there are limited researches that have been done in Africa, and that is an implication for the global disease burden, as there's a lot of diverse genetic biodiversity. There is a biodiversity that has not been captured in other studies that have been done outside Africa. I'll pass that down. The importance of understanding genetics is that the early prevention will promote early diagnosis, which will reduce the severity and prolong life without disability, precision and personalized treatment, pharmacogenetics, behavior change. This will help promote behavior change in vulnerable individuals. There is better disease understanding, which will lead to more innovations in treatment. Then there is public health planning, the policy development of strategies for the prevention, diagnosis, and management of cases, and then promote health equity, where all the diverse populations benefit. Then investigating genetic determinants of variation in disease susceptibility is one way to uncover new pathways in underlying disease pathogenesis. Understanding genetic in understanding genetic diversity in Africa could reveal unique disease pathways and guide global public health interventions. There are a number of ethical considerations that should be considered when doing these studies. That is data privacy, informed consent. Participants should participate at their own free will. The researcher should protect the participant from any harm, physical or psychosocial. The challenges that are faced here mainly are due to the inequalities in healthcare system, deficit genetic research workforce, lack of research funding, low awareness. There are limited infrastructure. Most health systems have no capacity for the genetic research. There are lack of biodata banks. There is no data sovereignty as it is not processed locally. Ethical and social concern. There are fear of misuse and discrimination. I will recommend, according to the study that the systematic review of the literature that is already there, the increased research funding, community engagement, integrate genetics in public health and health sector in general, then apply targeted sequencing, low-cost genotyping or mobile diagnostics, then use trained personnel and provide facilities for genetic research. And in conclusion, NCDs pose a global threat, and in Africa, the Africa genomic research is underexplored. Yet, Africa has the greatest genetic biodiversity, which could offer invaluable insights into disease mechanisms, resistance patterns, and tailored treatments. Therefore, we should invest in genomic resource, both in human resource, infrastructure, and in finances. Thank you.
Thank you, Lynette, for that presentation. We have moved away from what we are used to, going to persons and collecting data. This is something that is beyond more of a systematic review, and that is good. So I want to invite the next presenter, but before she comes, just come over. As you come, let's appreciate Lynette for that presentation. Thank you, Lynette. So after Purity, we're going to have Lillian Kenya. Lillian, are you in? Okay, fine, thank you. I'm looking to see that we have another presenter, probably the last one. Tanui Sharon Chemutai. All right, thank you. So I think we just need to give them a moment, and they're going to give their presentation. So thank you. Welcome, you may take over.
Okay, thank you. Good evening. I'm Purity Kadhambi, a master's student, medical surgical nursing. And let me take this chance to appreciate MUST for the chance, and also my supervisors, Dr. Mary Joy Kaimuri and Dr. Peter Kairemia. I'm presenting on the determinants of high blood pressure management among patients experiencing stroke, a case of Meru Teaching and Referral Hospital. Background, non-communicable diseases are a leading cause of morbidity and mortality globally, where hypertension is the biggest contributor of stroke, where stroke also is the leading cause of morbidity and also mortality in Africa. And in Kenya, 6.03% of total deaths are contributed by stroke. Now, despite the hypertension protocols in place, in Meru Teaching and Referral Hospital, 10.5% of hypertensive patients the year 2023 developed stroke, and this study is aimed to investigate the reason why that happened. problem statement. According to WHO, hypertensive patient, 4 out of 5 patients, 4 out of 5 patients, only 1 patient who is adequately treated for hypertension, and this is the biggest contributor of stroke. And despite effort to manage hypertension in Kenya, mortality is high. And some of the challenges that have been experienced is adherence challenges and healthcare system inefficiencies, which are biggest contributors to this. And in MTRH, according to the anecdotal data that was collected in the year 2023, indicates that the whole year they had 36.48 patients with hypertension, and out of those, 386 developed stroke, and now that is the reason for this study. I have 3 objectives for the same, as much as this is an ongoing work in progress. One is to determine the prevalence of hypertension, stroke, or morbidity among patients attending Meru Teaching and Referral Hospital. The other one is to explore patient experiences with the self-management of high blood pressure and to evaluate the delivery of hypertension healthcare at Meru Teaching and Referral Hospital. Methodology, I'm using mixed method approach and also convergent design. For quantitative data, the population that I have is 386 medical records for quantitative data, and also 71 healthcare workers. And also the sample size for the medical records was 80, according to the Amani formula, and also the sampling technique used for the medical records was systematic random sampling, and the healthcare workers stratified random sampling, where self-administered questionnaire was used to collect data for the 42 healthcare workers. For the qualitative data, I'm using an interview guide, in-depth interview guide to collect the data, and the purposive sampling is the method that I'm using, where I've interviewed 10 patients until I achieved data saturation. The analysis of the quantitative data, I'm analyzing using the SPSS version 27, and the descriptive statistics will be used to summarize the data and the inferential statistics to test the hypothesis. Then for qualitative data, thematic analysis will be has been used, though in progress, according to the Brown and Crack 2019, and following the 6 steps of analysis. And then qualitative data will be analyzed separately, and quantitative data will be analyzed separately. Then an integration through convergence will be done to compare the two of the sameness. Has been done for some of the data. Then quantitative findings, what I've been able to find is the prevalence of stroke was greater among females with 67.5% than males, and increase hypertension also and stroke is increased with age. Above 60 years were 44%. Then 91.3% of stroke patients and uncontrolled BP, 3 readings before they developed stroke, they were uncontrolled. Still, diagnostics were poorly utilized in managing these patients. ECGs, only 22.5% of the patients who are done ECGs, and the lipid profile, only 28.7%. And we know these are critical investigations for hypertension before even development of stroke. 71% healthcare workers reported also drug stockout as one of the challenge, and healthcare workers reported knowledge gap, 5.3%, and also 5.3% knew the recommended salt intake for hypertensive patients. 99% had no BP classification, and there was no common guideline that was used to manage the patients. Qualitative findings, these are some of the findings that I was able to get through thematic analysis. There was limited patient education because most of the patients relied on the peer information and also what they got from church. Those are some of the verbatim quotes that are indicated there to show that that is the information that they got. Then the second one is the adherence challenges. These adherence, some of the things that they mentioned was because of cost. The drugs were not there. They were expensive. The side effects of the drugs, the forgetfulness and work-related issues because they were busy at work. Others denied that they are sick, so they couldn't take drugs. Then self-care perceptions. Some perceived that managing your blood pressure through what they were taught positively, and they said it was able to lower their blood pressures, and also they were able to get their adherence support from even the family members, and there is the verbatim quote. Then the negative about the self-care, how they perceived, they felt they don't have enough knowledge to do the management of the blood pressure at home. Others felt that monitoring of the cost of those drugs made them not to be able to adhere to it, and also the monitoring of the BPs and cost implications, that is the verbatim quote. Then the health system gap that was seen was through the qualitative were the long queues. They complained of staying there all day at the hospital waiting to be reviewed, and they have only one doctor being waited by many patients. There were drug stockouts and rushed consultations because the doctor has a very long queue and staff shortages, and also they were not able to be transparent to their doctor because they feared because maybe the doctor might be rude to them. Then community reliance, most of them relied on family and community support for them to cope with the self-care at home. Then the convergence part, this is the area of convergence for what to compare the quantitative and the qualitative data. Most of them, the 71% of the healthcare workers cited that they have training gaps on management of hypertension, and out of the 80 patients, 78 of them were not cancelled according to the medical records. There was no indication, there was nowhere that it was documented and counseling was done on the self-care. The qualitative insight about it, about health education, patients also expressed that they mainly learn from peers and minimal education. Then healthcare system, there was inconsistent diagnostic use and also poor guideline adherence by the healthcare workers, inadequate drugs, healthcare worker shortage, and also still patient complained of long queues, drug shortages, cost of drugs was high, limited contact time with the healthcare worker. Because of time, allow me to move. About the adherence, there was no documentation on the medical records, on the patient counseling, on lifestyle modifications. Follow-up adherence was not done because there was no questions asked or documented about drug and follow-up adherence. And the patient also, on the adherence, on the qualitative aspect, cited that patients they were forgetting to take drugs, the cost of drugs was high, there were side effects, and those ones now shows that there were patient and system gaps that undermine adherence. Self-care, there was limited also documentation of lifestyle modification counseling to the patient according to the quantitative data, and also qualitative. Sorry for that. About the self-care, patients were saying that they were not able to get the diet that is required for them to feed. Also, they were not able to get time to do the exercises, and also the poverty levels to buy the greens and the fruits and what, meaning there was system not reinforcing long-term behavioral change. On the support system, we only got it through the qualitative insight, reliance on informal community and family support, which sometimes was absent according to the patient, what they send. The recommendations, one, for clinical practice is to train healthcare workers on use of standardized guidelines and also introduce home BP monitoring programs. For policy was to incorporate self-care competencies into national training for NCD management and develop hypertension management guidelines. For future research is more to explore on gender-specific barriers and cultural beliefs on hypertension management and evaluate on cost-effectiveness of different management approaches. Conclusion, many hypertensive patients at MTRH still developed stroke despite being on care. And then patient-related issues like poor adherence, low health literacy contributing to poor BP control, systemic challenges that we mentioned, diagnostic gaps, drug shortages and such. Then effective solutions to this must combine patient education, provider training, and better healthcare systems and supportive policies. Strengthening both individual capacity and health system is essential to reduce stroke risk as guided by WHO self-care framework. Thank you.
Thank you for that very nice presentation. I think you'll just stand a bit and wait for the questions, if any. So we start with her. If there is any questions on our presentation, please. You can see the way we are time bad. But of course, yes, Mr. Chege.
Thank you. Mine is very quick, just the flow of the presentation. The conclusion should come before the recommendations. So, yeah, but otherwise, good presentation. Thank you.
The second one and last for her.
Yeah, in your analysis, you said you are going to use chi-square and NOVA. We have not seen of any of those in your data analysis. When did they disappear to?
Okay, thank you. Thank you for the comments. Chi-square and ANOVA have not disappeared. This is work in progress. I'm doing it. I'll be able to do that.
Thank you. You can get seated. Can we get concern for the other two? Yes. You are presenting? Proposal. Yes, but we are having concerns first. Let's get concerns for those others. You can be preparing. Kenya.
Thank you. I would like to make some remarks for Monica Maina. Monica Maina's topic, I think, was effectiveness of Linda Mama on maternal health outcomes. The first remark is that in the problem statement, Monica, you quoted a number of statistics that didn't appear consistent. So I would like you look at it. Then, Linda Mama solves an access problem, financial access. What is the nexus with health outcomes? Build a nexus of the health outcomes with Linda Mama, which solves a financial access problem. And then number 3, when you speak about health outcomes and you mention complications like hemorrhage and so forth, how do you tie them exactly to the access problem of Linda Mama versus other possible reasons? And one of the suggestions I have is that if you already may be having the data, probably in your analysis, you find a way of tying down other factors so that you bring up the link between the access problem and the health outcomes. Thank you.
I believe that is a guide that he was giving you. I don't think you expected a response. No. So I have seen her taking notes. So any other for the other presenter?
And sorry,
yes.
I think the last one, measured effectiveness by 3 indicators of health, mobility, and satisfaction. Very, very complex indicators, so broad to measure one item.
You got that? She's taking notes. I had a comment. Is there another comment for the other presenter who was presenting for Samburu? Remind me your name. What was that? Yes, Jacob. You have a concern? Yeah, you can give.
Again, just a recommendation for Jacob. There's been a shift now to climate change. And I know your study area is one that has been affected a lot by climate change. So maybe you can consider also looking at climate change and how it affects mental health as one of your objectives.
Any other? Mine was a huge concern. You said the study was. I think you are editing an old study. You forgot to remove that. the study was? Do you remember putting was? It was the second one. Is this somebody else's study? Has the study already been carried out? Because you are presenting a proposal. I'm surprised the study was. And if that's the case, you must drop that because it's plagiarism. It's wrong. Okay? Or would you want to respond why there was that term was? Really? An error as was? I don't know. Yeah, it's a huge statement. It may be just be one, but it means a lot when we are looking at studies. Now, this is your Lillian. Yeah, we will have Lillian and then Tanui. Is Tanui here? Great. Those will be our presenters for now. And maybe we will close after that. So let's be very keen on the presentations. Please, thank you for holding on and continue helping each other so that we also get out of this all as satisfied people. Thank you.
Good evening once more. Okay, I'm Lillian, a MSc student in public health, and I'm grateful for being given this chance. Grateful to my supervisors, Dr. Kinoti and Ruto. My topic is assessment of tuberculosis preventive therapy uptake among healthcare workers at Meru Teaching and Referral Hospital. And on my introduction bit, TB preventive therapy are drugs given to individuals at high risk of contracting active TB. And health workers is one of the group that are at high risk of contracting tuberculosis. Tuberculosis preventive therapy reduces the risk of TB progression by 60 to 90%. And TPT can provide TB protection for 20. So this study will be conducted with the aim of investigating the TPT uptake rate, assessing healthcare workers' adherence and knowledge, and identifying factors influencing the uptake. Problem statement: tuberculosis remains one of the leading causes of illness and death. Meru County has experienced a consistent rise in TB burden. Healthcare workers in Meru County face a high risk of occupational TB exposure. Yet evidence on the effectiveness of preventive measures like TPT remains limited. Despite the high risk of latent tuberculosis, TPT uptake among healthcare workers is critically low globally and locally, with only a 2.1% of the same healthcare workers in Meru Level 5 Hospital. This alarming gap in TPT uptake among high-risk groups highlights the urgent need for research to uncover knowledge barriers and database evidence to drive policy reforms that strengthen TB prevention in healthcare settings. Justification: TB remains a major public health concern in Kenya and Meru County. Healthcare workers face a heightened risk of TB due to occupational exposure. There is limited research assessing TPT implementation among healthcare workers in high burden areas like Meru County. So this study aims to assess TPT uptake, TB burden among healthcare workers, identify barriers to adherence, and evaluate the effectiveness of current TB prevention policies. The research's main objective is to investigate the extent of participation in the tuberculosis prophylactic program among healthcare providers in Meru Teaching and Referral Hospital. Specific objectives: to describe the demographic characteristics of healthcare workers initiated on TPT at Meru Teaching and Referral Hospital, to investigate the adherence levels of healthcare workers initiated on TPT, to assess the level of knowledge of tuberculosis prophylactic programs among healthcare workers, and to identify factors influencing uptake. That is a study conceptual framework which has the dependent variables with sub-variables in it and the dependent variable, which all these independent variables affect the dependent variable. The methodology, the research proposes to utilize a descriptive cross-section survey design. It will be conducted in Meru Teaching and Referral Hospital. Study population is 214 healthcare workers, which is determined by the constraints-finite formula. Sampling techniques, the study proposes to use a simple random sampling technique. Healthcare workers at MTRH with randomly picked and voluntarily complete a structured questionnaire. Research instrument is a structured questionnaire. Data preparation, data will be prepared and cleaned through SPSS. Data analysis, descriptive statistics, frequencies, percentages, and impressions. Data presentation will be through tables, pie charts, and bar graphs. The research proposes to administer the questionnaire beforehand to refine and ensure its objectivity. Then ethical consideration. The study proposes to obtain ethical clearance from MIREC, NACOSTI, and County Government of Meru. Participation will be voluntary. Thank you.
All right, thank you for that presentation. Shall we appreciate her as she takes her position? Yes, please come over. Thank you. Please come over so that you can take the stage. We are almost getting to the conclusion of the day. So this will form the final presentation for today. We thank you, audience, for your patience up to this point.
Okay, my name is Tanu Sharon Chemtai. Okay, my name is Tanu Sharon Chemtai, an MSc student in epidemiology. My topic was on utilization of selected mobile phone applications among healthcare workers in Meru County, that is to combat selected infectious diseases. But I opted to go with one objective, that is my first objective, which is utilization of mobile health applications for infectious disease monitoring among healthcare workers in Meru County. Okay, infectious diseases are diseases caused by pathogenic microorganisms. They can be pathogens, viruses, bacteria, protozoas, and they can be transmitted from one person to another using or through different modes of transmission. Infectious diseases causes 9 million deaths, that is annually, in low and middle income countries, hence making it a public health concern, or hence making it there is need for research or doing research in this topic. Okay, malaria, TB, and HIV/AIDS are the 3 infectious diseases that I'm going to focus on. Now that those are the main diseases that have got high prevalence rate in Meru County. These challenges have put a lot of impact or has limited the health infrastructure. That is also in rural regions or in low limited or low resource limited areas. Many health systems lack effective or real-time surveillance, but with the utilization of mobile phone applications, we are going to get real-time or timely data, and hence enhancing or making it easy to prevent or even to combat these infectious diseases, or even making it easy to monitor, that is the infectious diseases. In my problem statement, in sub-Saharan Africa, it faces high infectious disease burden, that is according to Minor et al., whereby workers lack adequate tools for surveillance, Then in Meru County, that's according to the Ministry of Health, I've mentioned that TB, malaria, and HIV/AIDS has got a high prevalence in Meru County, and that's why my research will focus on the 3 infectious diseases. Then the mobile phone applications that I'm going to focus on are the integrated health information systems, telemedicine platforms, and even the home health apps used by healthcare workers in Meru County. A lot of people have got access to mobile phones, but most of them do not utilize them to combat infectious diseases or even to monitor the infectious diseases in the community. My research objective is to assess the utilization of mobile health applications for infectious disease monitoring among healthcare workers in Meru County, that is in Kenya. Then the core research question is, how are mobile phone or mobile health applications used by healthcare workers to monitor infectious diseases in Meru County? So I'll go and my structured questionnaires will have the usage pattern, whereby I'll ask questions on how frequent do these healthcare workers use mobile phones to monitor these infectious diseases. Then perceived benefits. What are the benefits of using mobile health applications to monitor infectious diseases? The barriers to use. Some can have some technical barriers, like access to networks, infrastructural barriers, and even the usage or the user level challenges. Then adoption factors. Training, I shall look at the training, whether people have been trained on how to use mobile phone applications to monitor these infectious diseases. The policy environment. Then in the user suggestions, I will look on the improvements needed for wider adoption of these mobile health applications in monitoring infectious diseases. Theoretical framework. My study adopts the technology acceptance model. That's why this study is going to explain how these healthcare workers accept on, or how these healthcare workers are going to accept on the usage of home health tools. Then in the perceived usefulness influences whether workers see home health as improving disease monitoring. Then what are the use or the effects of using these mobile phone applications? Are they practical and manageable in their daily routines? Behavioral intentions will reflect on how willing are these healthcare workers to adopt the use of mobile health applications in monitoring these infectious diseases. My methodology, the study design, will use a descriptive cross-sectional design. My study area is in Meru County, whereby I picked 4 sub-counties which have high prevalences of these infectious diseases, which is HIV, AIDS, malaria, and TB. My study population is approximately 2,000 healthcare workers in these 4 sub-counties. My sampling technique, I use convenience sampling to pick Meru County, simple random sampling to pick the 4 sub-counties. Then I used also simple random sampling to pick the respondents, that is the healthcare workers. My sample size determination, I used the Cochrane's formula to achieve the 385 respondents who are my sample size. The data collection instruments, I'll use both structured questionnaires to obtain the quantitative data. Then I'll use focus group discussion guide with 7 to 11 members so that to obtain the qualitative data. Then the questionnaire pretest, I'll do a questionnaire pretest so as to check for the validity and the reliability of my instruments. Then the expected results on the usage pattern, identification of commonly used health applications, and how frequent do these healthcare workers utilize those mobile health applications. Then what are the perceived benefits, insights into efficiency, then even improved disease tracking, that is improved infectious disease tracking, and even improved or eased communication through mobile health application. The barriers, challenges such as lack of training, poor connectivity or internet, limited institutional support. Then the expected results on the adoption trends. I'll check on the factors influencing whether or not workers adapt mobile health tools. Then recommendations, user-driven ideas for improving mobile health implications or implementation in rural public health settings. Then potential impact, the potential impact of my study. It will enhance policy formulation. It will also guide health ministries, NGOs, and even counties in designing appropriate digital health strategies, particularly in monitoring infectious diseases. Then it will also improve disease surveillance and response systems. Then also, this one will enhance, or this study ensures that or contributes to achieving the SDG number 3, that is ensuring healthy lives and promoting well-being for all. And it will also fill the gap, that is the literature gap, on mobile health usage among frontline healthcare workers in rural African settings. Thank you.
Congratulations, even for that. You have a question? Okay. Yeah, you can give her.
Thank you, Tanwi, for the good presentation. Mine is not a question as such, but when you are presenting your methods, you showed study sample as 2,000. I think that is not the study sample, that should be the target. So you have to look at it, because you've given us the sample, and then there is, you are calling it study population, so I think it might not. Oh yes, study population, correct. It's okay, thanks.
Right, anybody else? Yes, at the back.
Okay, thank you, Tanwi, for the presentation. I didn't quite get, is it a requirement that mL has to be used by the health workers? Is it a requirement so that now you are saying they have been trained and now they are not using? And is it a specific one that they are supposed to use so that then it's focused that you say, okay, they were trained on using this mobile app to monitor these infectious diseases at this particular time. This is the time period you are looking at to look at how they are implementing and why they are not implementing. Because is it an option that we have been trained, but we...
You want to respond to that? Yeah, she's there. Let her respond. Please give her the mic. Hello. Oh, yours is out.
Okay, there are some mobile health applications that most of the healthcare workers has been trained on, like the medical health records officers. Most of them have been trained on integrated health information systems, that is the integrated HIS. So it's a requirement for them to use that app in order to enhance data reporting or timely data reporting, like the DHIS. That's also an app that they have been trained on. But there are some other mobile phone applications that's not mandatory for them to use, like the telemedicine platforms. It's not all healthcare workers who can easily use them. So it's not a mandatory.
Thank you. For the other presenter, any questions? You forgot.
Oh, thank you. Mine is still for Sharon. Maybe if you could focus on one mobile application, because I'm thinking, and maybe this relates also to what was asked earlier, like the people at the health records, I would assume, will be using the computers they have with the softwares, and not necessarily the mobile phone. So if you probably look at those ones who are doing community outreach, probably, who are out there, those ones probably would use more of the mobile phone apps than those ones who are based in the hospital. So, and then maybe you can identify just one of those applications and see how it's used, as opposed to just leaving it general like that. Thank you.
Yeah, he's talking, thank you, Wanachege. He's talking of applications such as Kobo. Which other one do you use? Or which one do you think of using? Well, it's okay, just take note, Any other for this lady, Lillian, you Lillian? No other, no concern, you people are forgetting. You should have written down. They are now taking advantage of being the first. Okay, now mine is one question to you again. You said malaria, TB, and HIV. Which data, or how did you arrive to the conclusion that malaria is a burden in Meru? Because Meru, from what I know, the malaria pandemic areas that already have even had introduction of malaria vaccine is not anywhere within Mount Kenya. So how did you get that data?
According to the Kenya Ministry of Health, malaria was one of them.
Please check that data. Please recheck, because I am not sure you are talking of the same. Because for malaria to be considered as malaria, there must be a positive slide. Okay, there must be positive. So I think you will have to reconsider. I don't think malaria falls here. Having the information that I have. Now, considering that we have no other question, I will start by thanking you and asking Dr. Ruto, please, to come and give us a closing remark. As she comes, Simu Club. Thank you, Dr. Ruto.
Thank you, my sister. I have the honor to be the last one to talk, though the person who will pray will be the really, really last one. So I want to thank the management, especially the VC Mary University, for giving us this chance that we are here today listening to science and improving the lives of our communities. We are all here to improve the lives of our communities. That's why we have done all this research. And I want to also appreciate management. I want to appreciate the presenters. You presented well as a team. I want to really say thank you for making this day a great day. Without you, this day would not have been a success, so I want to appreciate you. I want to appreciate our rapporteurs, our chairs of session. I want to appreciate our visitors who visited us and improved our work. I think you've given very good comments to our students. They'll make better proposals as they go to improve on it. And I want to appreciate all the staff that are here, the KMTC students, Mary University students that have been with us all day. I want to appreciate all of you and say thank you very much for making this day a great day. And I want to appreciate our team, our support team. The systems have been working well. Without you, we wouldn't have communicated well. Thank you very much for making this day good. And lastly, I want to tell us, can we clap for ourselves? Maybe it's a kilo one for, what was it called? The Moi one, 1, 2, 3, or the bacterial one, whichever you choose. What do you want? Which one do you want us to go? The bacterial. So start with 5 and come down all the way to 1. Okay? Prepare, start. Thank you very much. I want to request one of us to pray for us. Any volunteer to close? And I want to wish you again, before the prayer is said, Johnny Masses back home. Take care till we meet tomorrow. So someone to pray for us today? A volunteer, please. You can pray for us. Thank you.
Okay, thank you. So let's bow our heads down for a word of prayer. Almighty Father, we come before you this wonderful